evening, everybody. On behalf of CIPLA, I welcome you all in Envision 2020. This Envision 2020 is going to see some of the great minds of Indian ophthalmology, and this would not have been possible without the mentorship of Dr. Lalit Verma. CIPLA Foresight is the third largest ophthalmic company, and during this unprecedented time of COVID, CIPLA Foresight has supported you in form of clinic sanitization, 3-ply mask, N95 mask and other COVID support material. Envision 2020 has been divided into 2 half-days program considering all major super specialty into mind: cornea, glaucoma, refractive surgery and retina. I won't be taking much of your time. I would like to invite all the dignitaries, those who are attending this first web conference, to come forward for lighting the lamp.
Good evening to you, one and all. Hope you and your family members are healthy and safe during this unfortunate and unprecedented COVID pandemic. All India Ophthalmological Society has always conducted different kinds of scientific activities for the promotion and mutual exchange of knowledge amongst the members of AIOS in the field of ophthalmology. Envision is one such event which was initiated only last year in association with CIPLA. But in this short span of 1 year, it has been recognized for its good quality of scientific content and exceptional faculty that have participated in Envision. With the advent and need of versatile virtual learning in today's unprecedented times, we have kept this Envision 2020 meeting a completely virtual one and have lined up an excellent faculty with great topics that will be of interest to all of you. On behalf of All India Ophthalmological Society, I would wish to welcome you all to this unique virtual conference, Vision 2020, where you will truly experience a unique blend of science and clinical practice. I declare Envision 2020 now open, and I would request the dynamic ex-scientific chairman, All India Ophthalmological Society, and presently the Vice President of All India Ophthalmological Society, who has done yeoman service to AIOS, to please take you forward in this Envision 2020 program. This will give you more insights of Envision 2020 as Dr. Lalit Verma unfolds the same. Welcome once again and enjoy Envision 2020. Thank you.
Hello everyone. I, on behalf of AIUS and all the speakers, chairpersons and panelists, welcome you all to this second edition of Envision. This time it's virtual because of the ongoing pandemic. But although virtual, it seems to be bigger and better because we have 2 parallel scientific halls. We also have more than 54 confirmed faculty. We have also areas for trade and we have a faculty lounge also. Besides talks and discussions, we have time for quiz, we have time for debates. So let's all learn and enjoy the proceedings of Envision web conference. Now it is my proud privilege to introduce the chairperson of the session, Dr. Mahipal S. Sachdev.
Audience link.
Okay, start
It
the
doesn't matter, it's fine now.
videos are disabled.
So we are live.
बेटे हमारा वीडियो तो ऑन करो. Good evening everyone. Can I request the admin to let the video, we can't start the video because the host has stopped it.
I think now we...
Okay, let me just see.
No, not yet.
Okay, fine.
So you need to stop sharing the screen, then you can share.
Okay, so who is sharing the screen? Can you just stop that? Who is sharing the screen? Yeah, okay.
Okay.
So Yeah, good evening, everyone, and welcome to Envision 2020. We are having a session in Hall B of cataract and refractive surgery, and I am happy to introduce the moderators with me. I'm Dr. Maipal Sajdev. Uh, I'm going to be the chairing the session, and I'm at present the president of All India Ophthalmological Society and also chairman and managing director of Center for Sight. I have with me the moderators for this session, and that is my dear friend Dr. Shashi Kapoor and Professor Dr. Rajesh Sinha. Shashi, as you all know, is somebody who has been a pioneer in ophthalmology, and he was maybe few people know, but he was the first person to install an excimer laser in India way back in in the mid 90s. Dr. Shashi Kapoor has graduated and post-graduated from the JJ Hospital and is presently efficiently running the Kapoor Eye Hospital in Mumbai. Welcome, Shashi, to this.
Thank you, Maipalji, for the kind words. Yes.
We have also Professor Dr. Rajesh Sinha, who has been a great, who was actually started as a retina person doing his senior residency, and then he's doing great work in anterior segment. He's presently taking care of the cornea, cataract, and refractive surgery services at Dr. Rajendra Prasad Center for Ophthalmic Sciences. He's also doing a great job as treasurer of the All India Ophthalmological Society. So that is Dr. Rajesh Sinha, and we have an esteemed panel consisting of Dr. Harbans Lal. As we all know, Dr. Harbans Lal has been the treasurer of the All India Ophthalmological Society. He works at Gangaram Hospital and runs his own center, ably assisted by his daughter. Dr. Harbans is one of the most proficient phaco surgeons that we have in India, and he was among the pioneers of those who adapted onto phaco technology. We also have with us Dr. Virendra Agarwal as a panelist. Dr. Virendra Agarwal, a student from SMS Medical College and then post-graduation from RP Center. And he's a very successful practitioner in Jaipur and has held several positions in Rajasthan Ophthalmic Society as also in AIOS. Also pleased to introduce Dr. Krishna Prasad Kudlu, whom we all know from Udupi, and he's a member of the scientific committee as of now, and successfully hosted all of us to the wonderful conference that he did in Goa. He's a pioneer again in cataract and refractive surgery. So I think that is what I will wish to say. This session is going to be on cataract and refractive surgery unplugged, and we will go on to the first speaker. There is a small change. I think Dr. Partha has to leave for another session. So Dr. Partha would be the first speaker, whom we all know is the chairman scientific committee of AIOS. He did great work as chairman of the ARC. He is a keen phacoemulsification teacher, as also for refractive surgeon. And Partha is somebody whom I have always seen working and working so hard and so diligently to teach people and to uplift the scientific standards of All India Ophthalmological Society. So Partha, please, the stage is all yours, and you will be talking on phacoemulsification complicated cases, a video assisted program.
Thank you very much, sir. Shall I share the slide, sir?
Yeah, please. Yeah, maybe just that's for you, Partha, super specialist, opinion leader, cataract. I think I said everything, BBI Foundation and reviewer for AAO. Over to you, Partha.
Thank you very much, sir.
Yeah.
Thank you so much. Thank you. Thank you very much, sir, and for that very, very kind introduction. And it's really a pleasure to be here amongst the stalwarts. And phacoemulsification in complicated cases, as Dr. Lalit Verma said, that I need to speak on them. So I'll present a series of videos of complicated situations and how we can manage them, there are so many multiple ways of managing complicated cases, and there are so many times that we have to take a call during the procedure, during the surgery, and each call is dependent on the difference of the surgical cases involved and the complications that come on. So the first video that I would like to share with you is something that we face, even the best of surgeons face, even the junior most surgeon would face, and that is a PC rent. So when a PC rent occurs, there are so many ways to skin the cat as it is, but at times it is definitely an enigma, and at times certain things, certain maneuvers, certain procedures can be done, and if it is possible. Now, this is a PC rent in a PPC, and this posterior polar cataract, we were expecting that something might go wrong, and did happen. So here we are with the PC rent, which is nearly like a hammock. And you can see that we have created an anterior capsular rhexis, which is actually anterior capsular rhexis, which is nice, neat, and round. Now, we were prepared for this patient with a single piece IOL. Now, with a PC rent of this size and magnitude, can we actually put in a single piece IOL? So a single piece IOL in the bag, is it a possibility? And a few minutes we'll answer this question. So the first thing that I needed to see is there vitreous in the anterior chamber? So there was not. And the vitreous was well settled. We had put in high molecular weight viscoelastic, and the anterior chamber was nice and deep, as well as the pupil was large. So we went on to this case, and we are contemplating an intraocular lens of a single piece. And I'll stop the video here. And this is a very important phase in the implanting of a single piece. So what I desire is to implant that lens in that hammock of the tear. So the lens goes in, my cartridge has gone in right in, and I'm going to land this lens on the pupil. And once the leading haptic is on the pupil, then the maneuvers will need to occur, and very, very judiciously. So this is the first go, and the intraocular lens lands on the pupil. With the landing of the pupil, and I'm going to stop the video once again, this is a very, very important technique where the angle of the haptic is bent so that it becomes a fulcrum. And with the fulcrum, then the rest of the procedure, it is very gently nudged in between the space between the anterior capsule and the toned posterior capsule. And this is a very important step where one has to be 100% sure that the leading haptic has actually gone into the bag. If it does not go into the bag, there is no question of the trailing haptic trying to be nudged into the bag. But I was sure there that the leading haptic went into the bag. In fact, the bag was inflated by viscoelastic so that the anterior capsule was up and the posterior capsule was down below. There was no vitreous between the lips of the capsules. And again, the second haptic, again, you can see the fulcrum and the pivot. And I very gently am able to place the trailing haptic into the hammock of this lens. The most important part, of course, we need to see whether there is any vitreous in the interior chamber by tricot assisted technique. And we need also to see that it is a well-centered bag and the viscoelastic has been removed. All this could be done under topical anesthesia. Every case cannot happen like this. Every case might not happen. It depends upon the surgeon, his choice, and the possibility of it. So we go over to the next case, and this is a case in which we have a large subluxation. It is a traumatic cataract, and there's a large subluxation. And in these traumatic cataracts, it's difficult to see what step is going to have what complication. So what we have placed is we have placed the high molecular viscoelastic, dispersive viscoelastic in that area of subluxation. And you can see the two rings that I have made, and one is a decentered ring on which the capsular axis is going to be centered. So the capsular axis needs to be centered on the lens and not on the pupil. So we have nearly completed with the cystotome, but it was not possible. So we went on to the microforceps, and the microforceps is an important tool in the completion of the rhexis, and this is very important, and that the tip of the microforceps has to be as proper as possible. So this completed. Next, we go ahead and make this incision, the main incision. Now you'll see it is a little against the convention, because I made the main incision in the area of the subluxation. Now this was a very deep-seated eye, and I could not approach it from the superior aspect, and therefore I had to go temporal. Now you can see that I'm not making too much of a headway, and I have to place these iris hooks to support the bag, because the bag, which I thought was just about 180 degrees subluxated, was actually more than that. So after placing in the CTR, you can see that the bag has more or less come to a position where I'm able to do a manipulation of the nucleus, a rotation of the nucleus, and managing the nucleus. It's not a very hard nucleus, but this nucleus needs to be well managed without any more subluxation. And the iris hooks are actually holding it in place. Yes, could have used the capsular hooks as well, and they are more atraumatic. But as of for this patient, we use the iris hooks. And iris hooks also do a good job, but one has to be careful that they do not hurt the anterior capsule. Now, at this point of time, I was apprehensive that we might have vitreous prolapse in the anterior chamber. And whenever the vitreous prolapses, we need to remove the vitreous before going on to the next part of the phacoemulsification. But there was no vitreous, so we went ahead, viscoelastic, and placing a single piece lens in the bag. So the CTR is in, a single piece lens placed nicely, but you can see the bag lens complex is definitely decentered. So what we do is, now vitreous had come in, so we do a limited vitrectomy to remove the vitreous from the anterior chamber, and we know that this bag definitely has to be settled. So we go ahead and try Hoffman's pocket here. Now with the Hoffman's pocket, and we place in the amid segment, one would do. And because this is not a case of progressive zonulopathy, so we are able to fixate the one amid segment into the bag so that the bag remains stable, and the rest of the zonules in traumatic cataracts are usually quite stable. It's very important that we do not entrap any corneal tissue while we are threading in and while we are needling in the railroad technique with the Prolene suture. And once this is done, so the importance of good dissection, as well as the lens being well centered and the amid segment being in place is important. However, since vitreous was there, so we again placed tricot in, and with a tricot limited vitrectomy, we were able to remove the anterior vitreous from the anterior chamber. So we come to the next case, and this is a case, as you can see, of a coloboma of the lens and coloboma of the iris, and there is also choroidal coloboma as well as it is a micro-ophthalmic eye and a microcornea as well. So now the first step that we would be doing is to remove, we would be placing in high molecular weight viscoelastic in that area of the coloboma, so that we do not have the trypan blue going in and staining the vitreous. So that done, and a good trypan blue stain of the anterior capsule is mandatory, because we need to be very, very careful while we are doing a anterior capsular rhexis. Now look at this. It's you can see this 5.5 millimeter rexus size that we want to create is nearly going up to the limit of the limbus, and the limbus would be just about 8 to 9 millimeters, and that's all. The white to white would be about 9 millimeters. It's a microcornea and such. And therefore, the importance of doing a very gentle and a very patient capsulorhexis is really important. And you can see that of the zonules would be there where the capsulorhexis margin is coming out, and we need to be very careful. Place in viscoelastic as many times as required because it might tend to drain out. And then the place where the coloboma is there, that is the area which has to be extremely carefully handled, because it is that portion, because the zonules are deficient. So actually the rexus can actually run out. So God's grace, we are able to get a nice and neat capsulorhexis here. And you can see that the pull is very important, and the pull has to be as tangential as possible, all the time looking at the edge of the rexus. So this rexus is nicely centered. The next part is quite easy. A very, very gentle hydrodissection. We placed in a little more of viscoelastic in that colobomatous part so that it would not let the vitreous which might come in. A very gentle hydrodissection. And this is, of course, a very soft nucleus which can be removed quite well. And once the nucleus is removed, the next part is very important. And the soft nucleus once removed, the next part is the part where we have to do the posterior capsulorhexis, and that is most important. So we do a posterior capsulorhexis there, all the time placing in viscoelastic and not letting the bag deflate. So now, initiating the posterior capsulorhexis with the cystotome is important, and then gradually making a neat posterior capsule. You can see that the wrinkles on the posterior capsule, but the posterior capsulorhexis must not run out. And again, it's a thin and diaphanous membrane that there is, and it needs to be done very, very carefully, taking patients, putting in viscoelastic, just optimum amount of viscoelastic so that it's not overinflated, not underinflated, and you can get off with a nice and neat capsulorhexis about 3.5 to 4 millimeters in diameter. So that done, that paves the way for an intraocular lens that can be placed inside the bag. Now, this particular lens we are very, very fond of, and it's the Acrysoft lens, which has beautiful optics, no financial interest at all. And the haptics can actually crowd in, and even in this colobomatous eye with a microcornea and a microophthalmos, it can go in, and it does not have a problem at all. The next part is most important, and that is centering this bag that is deficient with the deficient zonules. So we put in a CTR, and the CTR centers the bag complex along with the lens. So once the CTR, again, it is very important to place the CTR in very gently. And a word of, then we do the anterior vitrectomy, and after the anterior vitrectomy is done, so again closing the wound. And a word about the deficiency of the iris coloboma. Do we do a reconstruction of the iris there? The literature has shown that it is not necessary, because again there is coloboma of the choroid, and these are patients in which the vision is actually quite low. So the glare phenomena is not such an important phenomena, and such colobomatous eyes need not have a reconstruction of the iris. The last case that I would like to share with you, and this, of course, because Dr. Lalit Verma asked me to present some on the cataract and a vitreous. So this is a once in a lifetime case in which the Ozutrex that we found has come into the instead of the Ozutrex, which is 0.7 millimeters of dexamethasone, instead of going into the sea of the vitreous, it has got lodged in the lens of this patient. the surgery done elsewhere. And when we see this patient on the slit lamp, it looks a large osirex, as if the osirex, when we actually place it in the vitreous, does not look so large. So what was the reason? Of course, the magnification of the osirex in the lens. So here was this patient, and the left eye with diabetic retinopathy, the macular edema was increasing, the patient was losing vision, the cataract was increasing in this patient, and we had to do something about it. So what do we do? So wait and watch. Well, nothing would be done because the cataract would go on, and we would have the patient lose vision. The macular edema definitely would not settle. So we thought of doing something that was a little out of the ordinary. So all of us got together. What could we do in such a case? So one was, of course, removal of the cataract, removal of the osirex, placing an intraocular lens in the sulcus, and then placing another osirex inside the vitreous cavity. But was there any other way? So we thought about the particular way in which could we place the same osirex back into the vitreous. So what we do is we first do a neat capsulorhexis, anterior capsulorhexis, and that is well done. You can see it's quite a soft cataract, and we gradually remove the cataract as much as possible. And now you can see that the osirex is not really as large as it appeared to be on the slit lamp, and very, very gently we are able to dissect the osirex by blunt instruments from the nucleus, which again is a soft nucleus, and you can see very clearly that the osirex is very, very fragile, and it is actually dissipating its sediments. We are scared that we may break the osirex, but we are able to dissect it out as much as possible and move it to the periphery over the iris. But now the inevitable is going to happen, and we were apprehending now that the PC would go away any moment, and it has gone. Because once the osirex came in, obviously it was created with a rupture of the posterior capsule. So we remove a little bit of the cortical matter, and then we do an anterior vitrectomy. The vitreoretina surgeon is, of course, there on the standby, breathing down my neck, wanting to come in at any point of time. So we do a little bit of cortical removal, and with the cortical removal, things seem to be better, and then the vitreous surgeon takes over. The osirex is still there in the periphery, nicely lodged with viscoelastic, which has pushed it back there. So we remove as much of the VR surgeon removes as much of the vitreous, the PVD is there, inducing the PVD and removing the cortical matters which have fallen in. And then this osirex with that wisp of little cortical matter is placed inside the vitreous cavity. Will it work? Now we place the intraocular lens, a 3-piece intraocular lens, in the sulcus, and then capture the optic of this lens in the rhexis. So that entraps the osirex into the vitreous cavity, and that's the osirex there is. And over the next 3 months, this osirex melts away and reduces the macular edema. So this was a very, very heartening case. The patient from a vision of 660 gained a vision of 618. Of course, the RP is definitely not so healthy, but the patient did well and got back 618 and 10 vision, which was more than what we really expected. Thank you, sir. Thank you very much for your patient hearing.
Thank you very much, Partha, for showing us some difficult cases. Dr. Rajesh and Shashi, your comments?
Yeah. Dr. Partha, wonderful videos. Would you, your first case had a very large PCR. Would you like
video?
Hello.
Can the admin switch on my video, please?
Yeah.
Yes, sir.
So, Partha, could you give a guideline? What is the largest similar type of PCR where you would still say put a lens in the bag?
Sir, actually, this was a PCR in which the best lens and the safest lens is in the sulcus, and one can capture the optic of the lens in the anterior capsule, and that's it. But because the vitreous did not present into the anterior chamber, and because we could separate out the anterior capsule from the posterior capsule, and this hammock actually can lodge in an anterior single piece lens quite well if it is well placed. But if there is a mess of the vitreous in the anterior chamber, then that space is lost where the intraocular lens, the haptic, can go in. So
that's nice.
it's also a question of not only the largeness, but also the vitreous should not present into the anterior chamber.
Thank
What
you.
about capturing it?
No, sir, we did not capture it. We just let it be in the hammock, because if we capture it, then the hammock becomes unstable. We could have captured it anteriorly, but then that would mean that the haptic would tilt downwards, and we might actually lose the hammock of the position.
I guess in such a scenario, there's one precaution that one can take. I have done such scenarios. So while removing the viscoelastic, you have to be extremely careful that it doesn't rotate, because the rotates, then it's going to create problems. So you have to be very careful in removing the viscoelastic. That is one. The other case, I mean, you have shown some very good videos, Dr. Partha. Congratulations for that. One case, the one that coloboma one that you had shown, you had put Rapin blue. What was the age of the patient?
This child was, I think, 8 years old, about 8 years old.
8 years old. So just a couple of things. I felt that maybe the glow was quite good, so we could have done away without using the Rapin blue. And the other thing was at that age, since you're putting a CTR also, doing a posterior capsular excess, I mean, maybe 8 years of age, we can.
Yeah, Rajesh. Actually, why we took this decision, the other eye was even a smaller microophthalmos, and that eye had just about 1 meter of finger counting vision. This eye had approximately about 5 meters of finger counting, just about 660, and he was losing vision in this eye. So that is the reason we took up this eye, and he went to school, and he was going to school, and because he is a very intelligent guy, still keeps on following up. And he said that I'm not able to see the blackboard even from the front bench. So we said that let's wait. And obviously, because waiting would also determine if we could be more accurate on the biometry and everything. But then he was, losing vision, and that is the reason why we took this decision to operate.
So Rajesh, when you mentioned, maybe if you want to explain or I can explain, the use of trypan blue in such cases where there is a coloboma can actually cause a little more trouble while you're doing the surgery, because it can go back.
Yes.
The glow becomes a problem. And the second thing is that, again, since it's a micro-ophthalmic eye, at times there is a problem with the CTR, because the size of the CTR we don't get for small eyes, but ideally, because these people can make it, if you have a smaller CTR, that will be a much better thing. Yeah. Thank you very much, Dr. Partha, for an excellent presentation, and always a treat to watch your videos. Since we are, I think we're running a little late, let's go on to the next, and that is Dr. Sonu Goyal. Dr. Sonu Goyal, Rajesh, maybe you could introduce him.
Dr. Shashi is supposed to introduce.
Okay, Shashi, sorry. Shashi, go ahead.
Initial part introduction, Dr. Shashi. You have to unmute, Dr. Shashi. Shashi, you have to unmute.
Yeah. So Sonu Goyal is very accomplished anterior segment surgeon, and has been very prominent in a lot of conferences demonstrating his cataract skills and participating in refractive surgery discussions. He is based in Jaipur, Rajasthan, where he's a very successful private practitioner, and has made a number of presentations and won a number of awards. Welcome, Sonu, and looking forward to your presentation.
Thank you, Shashi, for that nice introduction. Uh, Edmund, can I just start sharing my screen? Thank you. Is my screen visible, sir?
Yes.
Okay. So after a wonderful presentation of Partha, I think wonderful complication shown by him. Let me talk about my biggest mistakes and the lessons in FACO. So I think in the COVID scenario, we all as practitioners are very, very scared. And what I recently had was this big five with me. We all should insist in seeing a dilated slit lamp examination. And most of these times, my fellows would do that work, do a slit lamp examination. Maybe they would miss the dilated, and then they would send the patient directly in the OR where I have these kind of scenarios. So, you know that in subluxation, with minimal to mild subluxations, they can be missed if you don't have a good dilated slit lamp examination. And even most of these moderate cataracts you can miss on an undilated slit lamp examination. So they would just look at the cataract, do the central fundus, do a good IL master, and admit the patient for a cataract surgery. So a recent patient which they had given to me was this wonderful, beautiful dangling cataract sitting right in my table after my anesthetist had put in some peribulbar. So these danglers, unfortunately, I had to address because COVID times you can't. So multiple side port entries. And what I learned from Professor Chi was this technique of holding bimanually and with a good two capsular access forceps, gradually pinching and grasping. And once I have a good capsular access, my most of the job is easy. I would use four capsular hooks here and support all 360-degree this wonderful dangler, which is being supported on the anterior vitreous face. So most of my job is easy once I've achieved a good capsular access, a good hydrodissection. The lens being quite soft, only the posterior subcapsular cataract, for which my fellow had admitted. The viscoelastic goes inside, and then I thread a capsular tension ring. So the bag has always to be distended because you have to have the bag not prolapsing once you're pushing a capsular tension ring. I always use a bimanual phaco here, bimanual aspiration here, and gradually clear off the cortical matter all 360 degrees. So what I achieve here is a nice clearance of the bag. Am I audible here? Shashi, I'm audible?
Yes.
Yes.
Okay.
Yes.
So a three-piece is my choice in all these subluxated cataract because if I lose my bag, I can easily convert to a glued IOL. So now I have successfully placed this inside the bag. And what is important, as Dr. Partha has rightly described, is two-point fixation. I always make a Hoffman pocket 180-degree apart. This is the standard railroad technique. A ninoprolene comes to the rescue. And yes, then the Ahmed segment would be threaded inside this. Care should be taken that the cornea should not be involved because at times the suture can be threaded inside the cornea when you're in trouble. So the Ahmed segment goes in and both ways 180-degree apart. I can handle this. But believe me, in the COVID time, it took me almost 45 minutes handling this subluxated beauty. But yes, I could do away. So the lesson learned, always insist on a full dilated examination of a patient before taking any patient for a cataract surgery. Another, the very next day, the same blunder was repeated. And believe me, they said they did a dilated examination. So they missed on a full dilated examination and again gave me this cataractus lens. The triamcinolone always goes in looking for any vitreous, push in viscoelastic, and what Partha described, a centralized capsular axis centered on the lens, not on the pupil. So the capsular hook is what is supporting here. A quick aspiration, the lens being soft, a capsular tension ring is threaded inside. And what I want to demonstrate here is the lasso technique, where I use the 8 of Gore-Tex, the two capsular hooks support. I do a quick aspiration, and then I fashion a Hoffman pocket. And this Hoffman pocket would be needed to thread So this is the 8 Gore-Tex, which is reversely threaded into the 26 gauge needle. And then this 8 Gore-Tex goes again through the hammer segment, pushed inside the bag, and the 26 gauge needle, which already has been threaded with the 8 Gore-Tex, goes transsclerally through the Hoffman pocket. With the Kuglin, I withdraw, make a loop, and externalize this 8 Gore-Tex, which has already been threaded inside the hammock segment. Now, believe me, all my subluxated, I have gradually shifted using the 8 Gore-Tex, and this lasso technique wonderfully works, and it's a very, very easy procedure. I acknowledge Professor Chi here for a wonderful contribution for teaching us this beautiful technique. I also acknowledge Professor Mahipal, who has always been teaching us for a good slit lamp examination before taking any patient for a cataract or a refractive surgery. So this is then externalized, moved from the Hoffman pocket. I just look at the lens back complex. Again, a 3-piece lens is again a lens of my choice. Gradually push in, nudge inside the bag very gently. I don't want to disturb any of the zonules. Looking into the lumera, the 3 images, the Purkinje images, I would then type this 8 Gore-Tex and centralize the lens back complex. And this is, at the end of the surgery, what I achieve, a very central, stable lens back complex. So thank you, my fellows, for making me blunt this, but at the end of the day, giving a good outcome to my patients. The lesson learned, all patients should undergo a dilated slit lamp examination by the operating surgeon and early recognition. You should always look in for pseudo exfoliation. You should always ascertain the extent of pupillary dilatation. The lens movement during capsulotomy is a quick indicator that the lens back complex might be unstable or you have weak zonules. A wider capsulotomy should immediately be thought of, a good hydrodissection, a proper wound construction, and yes, you should have an appropriate use of the support systems depending upon the zonular lysis. You can always do a combination of a CONE, AMAD, and multiple CTRs. A quick look of what we presented at the Bob Osher Symposium. So this is what went like a missile. So my quick take is always the instrumentation you should hold with both the hands. So I quickly started a phacoemulsification. I was just in a gist of moving the last case, a good capsular excess, the main port incision, and a quick phacoemulsification. Maybe just taking 2 minutes in the whole process. And I was trying to do a single-handed viscoelastic injection. And look, it's in the right hand. I just push, and there it is. It gets detached, and it goes and directly hits the posterior capsule like a missile. So I'm in trouble. I have a break in the posterior capsule. I think we have rightly been taught that all breaks have to be converted into a round regular opening for the lens back complex to be stable. So here is the break. I push in a high density viscoelastic, and with my Utrata forceps, which come into rescue, I fashion centripetally a round regular posterior capsular excess. And yes, once this is done, what is required is a triamcinolone staining and a good posterior vitrectomy. So I go 4.5 millimeter behind, do a good anterior vitrectomy, push in some good viscoelastic, and this is the lens. Now note, it's something different. I push in a 3-piece lens here, and this lens I would try to capture and just gradually look at the folds. So I've captured the lens onto the posterior capsule so that I have, see now, this is what I try to do here. So I have a very stable lens back complex. So the lesson learned is very important, that the instrumentation should always be properly taken care. The last in the series, what I present is a recent case, a preloaded This is no financial interest from the Zeiss. The lens opens and the haptics open in this way that they create a decimeter axis 360 degree. So very nice axis of the decimeters has been created by the lens as it unfolded, and reason was that the eye started to gain pressure, a very high pressure, the iris starts prolapsing, and this is what the remnants of the decimet I have. So immediately push in some good mannitol, get the pressures lower down. I again push in the IOL inside the bag. So look, still the pressures are high, but I gradually manage to push the lens inside the bag, and yes, gradually nudge the haptic inside. The pressures start going slightly low, so I have a deep chamber now. Now what is required is to wash away the viscoelastic. I contacted my cornea surgeon. There was no corneal tissue in rescue. The only hope was the remnants of the decimates that I had. So whatever we learned from Dr. Rajesh Sinha through his multiple live surgeries that he has been performing across Rajasthan. So we got these decimates rightly placed, gently push, and then I try to bubble this. If you note carefully, it was torn in a semicircular fashion. So I could make out the edges and I gradually bubble, rebubble, and then try to achieve the appropriate position right in place. And believe me, day one, it was well centered and we could achieve a good result. So for all decimate detachments, another case, I think bubbling, learning should always be there, and you should always be having a little patience to deal with on the table detachments. So thank you very much for your patient listening.
Thank you, Sonu, for some wonderful videos.
Thank you, Dr.
Rajesh?
Maybe we can have the panelist say something. Dr. Harbans, maybe you want to say something? Varinder Agarwal, anybody? Muted. Harbans, you are muted. Harbans, please unmute yourself.
I think in the second last case where the cannula injured the posterior capsule, in that case, normally I put the tricot after putting the IOL so that the tricot will not go into the vitreous cavity. And if the axis is well centered and you are going to put the 3-piece lens, then probably you can put the 3-piece lens straight away without doing PCC and do the optic capsular capture and then do the vitrectomy finally from the anterior root itself, which can save time and can have a good results. So it was an excellent video doing PCC and then going through the pars plana, but all of them it may be a little difficult. So the simpler option maybe just put the lens, do the optic capture, constrict the pupil with the pilocarpine, and then do the vitrectomy, anterior vitrectomy. That's it.
So I think that's a wonderful suggestion, sir, and I fully agree with that. But in this case, the moment there was a break, the vitreous had presented. So I just wanted to be sure that all the vitreous gets cleaned off before I put in the IOL to just avoid the tilting or decentration of the IOL. But your suggestions are well taken, sir. I think in most of these cases, you would really not require going through pars plana and doing all this complex posterior capsular axis. Well taken, sir.
Excellent. Last case was very well managed where the decimet got torn and everything was really perfect. It came out very well. Very good.
Thank you very much, Dr. Harbans, for your comments, and thank you, Sonu. I think we are slightly behind schedule. So we go on to the next, which is a debate, and I think this is one of the debates that figures everywhere, and that debate is on femtocataract surgery. Do we really need it? Rajesh, would you be introducing Dr. Himanshu and Harbans?
Dr. Shashi.
Shashi, again Shashi.
Oh, yeah, it's supposed to be Maipalji till 7 o'clock, I think, and then 7 to 8, Rajesh is introducing everybody.
Okay, go ahead, go ahead. Sorry, go ahead.
Sorry. The slide has not come up.
You know them well enough here. You can introduce.
Yeah. Oh, now it is Maipaji, the two people are.
I will
Ford
just
is.
I'll just share the slide, Dr. Shashi, for you.
Thank you.
Oh, I think you have to introduce Dr. Himanshu and Harbans. Himanshu
Yeah.
will be speaking for Femto, and against would be Dr. Harbans.
Dr.
So
Harbans.
Himanshu. Yep.
Yeah. So Dr. Himanshu is a very successful private practitioner in Mumbai, and I think he is trained as a retina surgeon and then converted to anterior segment. So he's very well versed, and he has performed a large number of refractive surgeries also, and really looking forward to this debate. I think the opponent is Harbans Lal, who is like, needs no introduction types, author of so many books, numerous live surgeries, numerous articles, numerous posts held in DOS in all India. And I think he's everywhere. He's done it all. And good luck and looking forward to this debate. Thank you. He's against, yeah.
Dr. Shashi Kapoor, we also want you to have a poll before the debate.
Yeah.
So
Yeah.
I'll ask the moderator to check the poll, to get the poll.
Yeah, so before any debate, we normally have a poll and then we decide to see as to how the people have been influenced. So can you have the poll question? Who's going to put up the poll? Yeah.
Yeah, I put it up, sir. Dr. Shashi?
Yeah. So do we really need femtocataract surgery? So I request the audience to please click on the icon and send your opinion. Rajesh, how many seconds?
You have to wait for 1 minute and we will share the...
The panelist cannot click, right?
No, the audience will do it.
Yeah.
You're not allowed to click, sir.
Unless the debate is gone by one vote, then casting vote Maipaji in favor of femto.
Oh, this is known. The answer would be no for sure. Doesn't matter. So, do you announce the result now or later? Okay, no. Yeah, see, yeah, my 85%. So that means 15% of people own femtos in India. Okay, Himanshu, all yours. You own. Oh, how did it become 20?
They just bought a machine.
No, is it? There are only 15 votes, right?
No,
15.
Still people are voting for femto. They are slow.
Do we really need? It says 015. That means the number of people who have voted is.
Number of people, yeah, who voted are 15.
But percentage it is 20.
Okay. So can you take this off now?
Admin? Yeah.
Yeah. Himanshu?
Yes. Thank you. Thank you very much, Dr. Shashi Kapoor. Thank you, panelists, and thank you, Sipla and Dr. Lalit Verma. I have a formidable opponent in Dr. Harbans Lal, and the crowd waving at 85% to a 15%. So interesting job in front of me. I just would request one thing, that I can cut my talk to 30 minutes and give me 2 minutes for refutal after Dr. Harbans Lal's talk. That's a request that I would have, Dr. Shashi Kapoor, if that you allow me. Let me share my screen now. Is my screen visible and am I audible?
Yes, yes, yes.
So femtosecond surgery is the way to go, is something that I'm going to tell you, something very important. Progress, science, evolution, we have gone through that. You know what is premium surgery? It's in the mind. There is nothing premium about premium. Everything that was premium once upon a time is a necessity. Air conditioning when I was young in school was a premium surgery. You know, your car having a motorized turning around in your wheel, even your car motors, everything was supposed to be a premium. Today, it's a standard feature that you have. So what used to be premium is standard. So that's called progress and evolution.
So evolution of science and technology meeting patients' needs and expectations. It's not just our needs, the need of the time, need to progress and need to move ahead in life. So it will be at the forefront of human life for years to come. That's what Einstein had said way back. And this is what I'm trying to tell you, that it's not innovation is not premium. There's nothing great about in premium. If you do not innovate, you perish. If you don't move with time, you perish, you disappear. So we have to move with time. We have to understand what's coming. We are not talking about luxury. We are not talking about that. But when we are, what we are really talking about, how science has evolved as a necessity to give fantastic results at every given point of time. So we have seen the growth that has happened over here, that we started surgery and evolution from extra. We were very happy with extracapsular when we were doing our postgraduate days. Nothing wrong with that. We did intracapsular once upon a time. We learned what was extracapsular. We did surgery with 180 degrees incision and stitches from 8-0 to 10-0. And then we went into a phacoemulsification 2.8, 3.2 to now 2.2. Well, we evolved, we learned from our mistakes, and that's what beauty about modern medicine is. We learned where we were going wrong, what we were doing, and how we can improvise ourselves. And that is evolution everywhere. We transit from silicon lenses and hard PMMA lenses to foldable lenses, and you have the actors of lens or whichever lens that you want, and which is why it has been proved. So it's evidence-based medicine. So we will progress to preloaded IOL. Actually, it was the companies which were wrong by not giving us preloaded IOL. It was our birthright to get it. I remember once upon a time earlier on, they used to charge us for the ultraviolet segment in your IOL. They used to charge you for aspherical. They used to be spherical lenses. Now, what's so great? They were behind. They were lagging in technology. They did not give it to us. So that was not a premium. They used to charge us a premium for a nonsense reason. It was a necessity. So what I am trying to tell you is that there is nothing premium. Everything is bare necessity when it comes to human life and health. And President Trump is going to prove that. Corona is going to prove that healthcare is the ultimate thing, that everything else, a Rolex, you can do without. So well begun is half done. I think this is the biggest lesson that I've learned, and everybody has learned. A good residency or a good fellowship training takes your life much more easier in your private practice. If you've got the best equipments, ultimately anything that is well begun, any chapter, because otherwise you will take 4 steps ahead and 10 steps behind. So the planning and the architecture, if it is ready there for you in complicated cases or otherwise, it can make your life a lot more easier. The invisible and invincible third hand, the femtosecond laser cataract surgery. Here, what is the most important thing that I'm trying to do? When I'm a surgeon, what am I doing? What eventually is needed? Safety, efficacy, reliability, repeatability, accuracy, precision, and consistency. It's like saying that however great a surgeon I have around me, a lot of good surgeons, that making that roti circular every time that the mother can make, it's never going to be circular. Only a machine can make it circular. So however much we do, but we also need the robotic part in our life, the manual. Why should we not have it? If we can make things more safe, more efficacious, more reliable, more repeatable, and consistently accurate, is it not a great idea? And believe me, in most of my talks that I've had in the past couple of years, I asked everybody, all the surgeons sitting in a room, given a choice, if it is your father's side, mother's side, put money on one side. It's a VIP patient. It's a one-eyed patient. What would cool your nerves? What would make you more comfortable? A good beginning where you're, in a shallow AC, compromised cornea, you have a good rexis, you have your wounds which are there, and a pre-chopped nucleus. It's a no-brainer, friends, that you need that, because that's what you want, results. You want to start with your heart rate at a good rate, and that can happen. So the femto laser surgery is an absolute necessity. We have to move, and we have to see that it's the best thing that we can do for our patients. The only thing always back of our mind when we were studying in undergrad days was, oh, CT scan is a bad thing. It's very expensive. MRI, very expensive. But the patient doesn't give a damn. Put money on one side. For once, think in this lifetime, would you want to miss something before you die? You want to have all those things which you can give to the patient for that little happiness. Here, you can see how beautiful the incision is, the corneal incision. Very well centered, good valve. You can be precise about that. The LRIs I'll come to in a little while. Every small part. If your blade is not good, you will have some ragged incision. And if your incision is not good, believe me, leakage from the side or the lens, the desmetorexis, all that can happen if your wound is not adequate size, not matching with the probe. The beautiful that Rohit has shown from Amritsar, that your iris floppy coming out is because a larger incision and your equipment on the side was a smaller one. So fluid used to egress. Now everything can be planned so well with this machine, and you can see that you get out very quickly. So the corneal incisions is one part. Here you can see that you can have the depth of your cataract. How big is your cataract that you're looking at? If it's a small pupil, how are you going to manage your rexis? How are you going to manage your nucleus management? This is something important. Now look at this patient. One-eyed patient, bad cornea, hazy, just on the verge of dying, refusing to get himself. And we all know that one-eyed patients don't want to come to get it operated. They want to come the last. And this is where they have a problem. Look at this, where your pulse rate is pounding. You have a shallow anterior chamber, hypertensive, diabetic, bull neck, and whatever you have. Is a rexis a good idea? Very difficult. But look at what an effortless thing that you can have. Like as I said, a one-eyed guy, a corneal haze, endothelial cell count is low. Here you have a lovely rexis which is happening in no time. Your nucleus is pre-chopped here. It's there, sitting there, when just to be pounced upon and eaten up without problems. Isn't that an interesting thing? Now look at that. You have a small floppy iris. You have iris which is floppy, and most of these guys today that we have prostate medications going on, pupil is bad, and you possibly did not use a Malugin ring for whatever reason. But whatever way, if you want to stay in the center without messing around, you have a pre-chopped nucleus which is ready to be eaten up. Now see how simple it is, without much movement, without much fluidics. Very important to me. The iris becomes more nasty with more fluidics. And God forbid if you touch your phaco probe there. You have very easily chopped nucleus. Look at that, how beautiful it is. It just comes off, it peels off, and that makes your life easier. And of course, the biggest thing, you have a subluxated traumatic cataract. If you can see on the right side, you have the nucleus which is tilted down. Your vitreous is there. Your rexis is going to be a tough scenario. Here, you can go ahead and plan your rexis. You can go ahead and have a fantastic beginning to the whole situation. And look at that. Your rexis is planned. You are ready with your rexis. You are ready to go ahead and remove the nucleus fairly well. You can manage it without much complication. You don't have to do a great amount of hydrodelineation dissection. This helps other zonules to be taken care of. So even if you wanted to put an emethyl implant and or an endocapsular ring, life is a lot more easier. As I said, well begun is a job half done already. So that's the subluxated lens. Of course, the next is the posterior subcapsular cataract, congenital. Look at the beauty with which you can manage it. You have a cylindrical pattern. So you can go ahead, have a lovely rexis. You have enough place in case if it's a perforated behind, you know what can be done. You can go ahead and do a cylinder. And if you look on the right side, the depth of your posterior capsule, you can see whether it is perforated, not perforated here. Your OCT is giving you real-time performance. How bad is the thick posterior capsule? How bad is your nucleus? Look at how easily this nucleus will walk out in cylinders, and you can remove the epinucleus in the end. It's a great third hand, no question. However great surgeons we are, definitely we need help of any of these criteria to see that our patients do well despite all our problems that we may have. You have various patterns available. You have the circular pattern, you have chop, stop and chop, you have multiple nucleus fragments which can be given, you have a sieve-like pattern. You can do what you want. You can play around as much as you want in various kinds of cataract and even in a smaller pupil. So chop plus cylinder, fragmentation for hard cataract, cylindrical pattern for PPC, two chops for soft cataract, name it, whatever. You have the tilting automatic which can be helping you there. So now everybody talks about that. What's so great? I'm a great surgeon. My capsular axis is consistently fantastic. My 5.5 and I have lovely. But if we are looking at a multifocal lens, if we are looking at any of these, even 0.25 dioptric correction on a lens power, which we are complaining with the companies that we have only 0.5 diopters change between the lenses. If your lens is not well centered, if your capsular axis is not good, it can change your results. A 4mm rexis results in longer postoperative thing, and a 6mm rexis for the type of IOL used. To ensure that your IOL position in the bag matches the anticipated formula used to calculate its power, the rexis should be round, centered, and smaller than the IOL optic. In case you want to capture the IOL on the upper side also for whatever reason, your rexis will be very well helping you. Look at this, the effective lens position. If the IOL is 0.5 millimeter posterior to the assumed plane, a 21 diopter lens will produce a 20 diopter of correction. So you are grossly one diopter off if your effective lens position is not good, because if your axis is not good, that can happen. And if an IOL is 0.5 millimeter anterior to the assumed plane, the lens will produce that much less correction. So this is where we are. And the laser arcuate, every time you use a multifocal lens or a EDOF lens or a extended, whichever lens that you want to use, trifocal lens, your biggest problem happens is a little amount of residual astigmatism, that happiness factor of astigmatism, the blurring, the patient which will complain. Here an LRI is the easiest thing which you do in next 20 seconds, and every patient you can try and give the best possible corneal correction. What's wrong? It's fantastic. You have so much of coverage. So the square edge, uniform depth, precise, reproducible arc shape, length, diameter, all that proves that we can go ahead and do also the improved refractive cataract surgery. If what we are looking at now, no stage, no pain, no putty, go back to work quickly. You know how we tell the patient with a tall claim, no chashma. Well, if we are anywhere close to that, this is one more thing in our armamentarium besides the surgical skills. So the position, predictability, uniform shape, capsulotomy, astigmatism, reproducible, corneal entries, arcuate, as I said, so very important. If your blade is not good and your entry is not good, you will pay a big price during the surgery. Your cornea can get messed up and your wound can leak and your iris can create trouble. And the early wow factor. And believe me, once you start using it, your fluidics are less. You will see that the patient gets extremely happy. And of course, the biggest study, which is to me, we are getting younger cataracts. We are doing a lot more young people between the age of 45 and 60 now. They're going to live with the average longevity increasing. You need these endothelial cells when they become 85, 90. And since there is less amount of fluidics and less phaco energy, your amount of corneal endothelial cell loss is way less. Edema would be less. And patients with pre-existing corneal endothelial dysfunction, definitely this is the way to go. How to achieve laser-like outcome in cataract surgery? Effective lens position, better control on incision architecture, minimizing phaco energy, effective managing of corneal astigmatism, safe, predictable, reproducible, consistency is what the surgeon expects. I mean, the patient expects from every surgeon. You might have done 100,000 cases very well, but we all know how we sweat in the 100,001 case, and that makes us human. This can help you to get better outcomes. So endless benefit that I've seen. Well, we move it time. It can be in smaller AC, small pupil, repeatable rexis, reduces tissue damage, and I'll keep repeating that because the eye is really quiet. From the patient point of view, minimum post-op surprises because a lot of things are in your hand. Corneal incisions are healing faster than routine. The SIS consistency is there, and it reduces possibilities of disturbing the intraocular structures by reducing the phaco energy. Very important. And pre-existing corneal astigmatism, in almost every case, you can take care of that. It enhances, finally, eagle vision or 20/20 or supervision is not just surgery that the surgeon does. Overall experience of the patient during the whole surgical procedure, how well they heal, how painful it is. Here it is to have you an invincible hand to thank you and support you for your surgeries in complicated and VIP cases, and including your eye. I promise you, the way to go is femtosecond laser. Thank you very much.
Thank you, Manchu. Well done. And we see now how Harbans counters that. Harbans Laj?
Yeah. I
Hanji.
think the what Himanshu had presented, there was no evidence whatsoever. It was totally eloquence based and eminence based presentation. There was not even a single study quoted in any of this presentation.
Can the admin remove this slide so that Dr. Harbanslal can share his own?
Share your screen. Why my presentation is not coming? Can you see my presentation now?
Yes, yes, yes.
And secondly, so far as the round roti is concerned, I rather prefer a tasty and well cooked roti than a round roti actually. So it should be well baked, nicely made, and tasty one than to have a little better shape. So now we come to the main debate. As doctor, we admire, appreciate,
Sir,
and
can you go to slideshow?
is it okay now?
Yeah.
So as doctor, we admire, appreciate, and love to use the new technology, provided it is safe, superior, and cost effective for our patients. Main issue for adopting flags are logistics, surgical steps, surgical complications, surgical outcomes, and is there any alternative technology available? So logistics are totally against the flags. You need extra space, which may be very difficult to get in Bombay. Then you need extra money, of course, which very few can afford. And time taken per surgery is more than the traditional phacoemulsification technique, which is nearly 11 to 12 minutes per case. Then it does not take away any surgical step. That means you have got to still make an incision, you have got to do capsular excision, you have got to do hydrodissection, nucleotomy, epinuclear removal, cortical aspiration, IOL implantation, everything is there. Extra step is added, that is docking, which has got its own complications and problems. Orbit, neck, back, if there is any issue with them, patient may have difficulty in docking. Patient must be still. There are issues of suction loss, and there may be computer issues in this. And so far as the incision is concerned, we know that the limbal incision heals better than the corneal incision. That means where the oozing is taking place, healing is best over there, not the clear corneal incision. And the clear corneal incision, the risk of endophthalmitis increases, and even the presence of the arcus, you might have to make a more centrally placed incision. So much so, many of the plaques surgeons are stopped making incision with the femto. They prefer the blade incision. If you got a good sharp blade like Alcon, the absolutely smooth incision. I mean, you can use the diamond knife. And if you see the regularity and strength of the incision, the manual incision is much more smoother than the incision by any femto, which creates multiple small punctures over there. Then hydrodissection may be difficult and dangerous at times because they already created a bubble which may be there in the behind the lens and between the capsule. Then nucleotomy, nuclear removal and cortical removal, this needs hand, eye, foot mental coordination as in phacoemulsification. You can't just close your eyes and can do it. Instead, you need to have a phaco machine to go and remove all these things from the eye. Now, let's say we have spent a lot of money, we have a lot of skill, and everything is all right. Are the surgical outcomes better with this? This is where is the key. This is what my friend has been trying to emphasize. He has been focusing more on evolution, more on words than actual outcomes. He has not shown any presentation where the comparable outcomes of the multicentric trial was there. So when we try to see surgical outcomes, how is the endothelial cell loss, centration of the IOL and circularity of the CCC, visual outcomes and refractive outcomes. These are the parameters to assess any surgical outcomes. So there are many studies. This is one of them, 988 plaques and 888 conventional surgery. Corneal thickness and endothelial cell count after 1 week was the same. There was no change. And if we see the centration of the IOL, now horizontal decentration and a vertical decentration, there was no difference because these lenses are so tacky, it sticks to the posterior capsule. It does not get decentered very easily. Even if you want to remove them, it is very, very difficult to remove them. And if you see the visual outcome was better in cases of phaco 6.6 in 29.6% of the patient, while femto only 19.9%. And if you see the refractive outcome, what was the refractive error? 0.5 diopter in 72.2%, and in a traditional surgery, it was 82.6%. And 1 diopter, 93.7, 95.8. So there was no difference in the refractive outcome. There was no difference in the visual outcome. In fact, it was written on the worst side. And there was no difference in the endothelial cell count. So if you now come to the surgical complications, okay, we accept that there is no advantage of the femto so far as the
traditional outcomes are concerned. Does it make the surgery safer now? So after putting on so much an effort, and this is the biggest of the all lies, that the flax is safer than the conventional phacoemulsification. During learning curve, in the first 200 cases, after putting so much of money and sweating and paying the installments of trying to meet the targets, first 200 cases, suction break is 5 patients, manual corneal incision needed in 26% of the patients, pupillary construction in 19 patients, anterior capsular tag in 21 patients, anterior radial tears in 8, posterior capsular tear 7, and posterior lens location in 4%. And this is the initial 200 cases. Even once you're mastered, in the next 1,300 cases, the suction break was 0.61%, manual corneal incision, all these problems were there, and we'll compare with the traditional surgery. And when you do the docking, the IOP may go high and it remains high for quite a reasonable time, 3 to 5 minutes, and which in a compromised optic nerve or vasculature retinal pathology may create a problem for the patient, like a post-glaucoma patient or the patient who has got optic nerve which is 0.9 cupping already there. Now, if you see the perioperative complication in these cases, in capsulotomy, this is PCS is the manual cataract surgery and LCS is laser-assisted cataract surgery. Incomplete capsulotomy in 5, 0 in manual, anterior capsular tag in 15, 0 in manual, anterior capsular tear 15, 3 in manual, posterior capsular tear 11, 2 in manual, corneal haze 6 and 0, corneal epithelial defect 7 and 0, Descemet membrane trauma 3 and 0, duodenal dialysis 1 and 2. So you see all the complications are much higher in the laser-assisted cataract surgery than in a conventional surgery. And there are many studies for that. And then the post-operative complication, not only the intraoperative, post-operative ocular hypertension is more, corneal edema is more, cystoid macular edema, because when you do the laser, it may reduce the phaco ultrasonic energy, but it gives its own energy, which creates so much of cytokines and other inflammatory mediators that it causes cystoid macular edema. Anterior uveitis is more, retinal detachment is more, IOL subluxation is more. Then subconjunctival hemorrhage complication unique to flax. Subconjunctival hemorrhage is only in flax. And the first contraindication of flax is that if you are done a manual cataract surgery in the one eye, please do not do flax in the other eye. Well, now patient will be able to compare what he got first time, what he got second time. Well, he will have more pain, he will have more redness, it will take more time, it may have more complication, and he has already paid more. So don't do flax if the patient already has got one eye done by conventional cataract surgery. This what itself shows how inferior the flax is as compared to the conventional surgery. The capsular block, suction loss, meiosis. 32% of the patients will have prostaglandins and cytokines causing meiosis of the pupil. So you got to do, if the pupil size is 4 millimeter, you can do capsular excess of around 3 millimeter. I don't know how he showed that it is good for a small pupil. I mean, what is the problem in putting a ring inside and do the proper rexus size at least, not to make a small rexus because you want to extract money from the patient and making 3 millimeter of capsular rexus over there and then making all the surgical steps difficult. When you want to remove the nucleus, it is difficult. You want to remove the epinucleus, it is difficult. Cortical removal is difficult. Putting IOL is difficult. The more chances of fibrosis and the patient is a diabetic or some posterior segment problem, then you are left with a very small capsulotomy over there. So there is no way you should do a small pupil with the small capsulotomy. I think that is a really not on. You have got to dilate the pupil or use the amalgam ring or the iris to whatever it need to be, but you need to make a proper rexus. And acute IOP rise is unique to the flax. And then this is the latest study where this is a large study, which has shown that I'm just giving you just a small PCT is 0.7% in cases of flax versus 0.4 in phaco. This is 4,987 and 2,840. Post-op visual acuity lesser by 5 letters or more. 1% is in flax and 0.4% in a conventional cataract surgery. So this is a very large study. And there is no, and the corrected distance visual acuity is better. Biometric predictive error is the same. So in conclusion, the study concluded the flax visual refractive outcomes no better and post-operative complications low in conventional phacoemulsification than flax. So till now, none of the debates are gone. Any of the flax supporters have shown, and there are so many femtolaser installed. Why don't they come? So none of the multicentric trial is they are in a hard cataract, subluxated cataract, and this, but not in a real good this thing. So the limitations are there. Orbit and neck and spine, uncooperative, mentally retarded, neurological patients, corneal obesity, micromegalocornea, pediatric patients. There are many limitations of this technology. Astigmatic correction is again biggest flaw in the system. We have been doing LRI, rejected. Why? Because the vision is not stable for 3 months. It causes much more instability of the tear film. And whatever result you get within 3 months, it comes back. So LRI was never a good procedure. So whether you make a relaxing incision with the laser or with the blade, it makes no difference. You can make a diamond cut, it will be the same. And if you need to do it, actually, then do it post-operatively. If you want to make a diamond cut or the laser, your PRK can do better job, your IUL can do better job, PRK or LASIK can correct all the refractive whatever you had. So why to charge 1 lakh extra in the beginning? Why not to do the laser afterwards if you need to correct the refractive error at all? So the LRI are the, and till now there were no established nomogram available for that. Everybody is doing according to his own way. All know this far better result. Now the toric IUL available which can correct 0.5, 0.75 diopter of astigmatism. And secondly, astigmatism is again at 1 millimeter astigmatism is different, 2 millimeter is different. The different machines give a different reading. There's a posterior corneal astigmatism. So correcting 0.25, 0.5 is a very, very difficult target to achieve by any method or by any technology. So thank you very much for your kind attention.
Thank you, Urbans. Very well defended.
Yeah, so do we get 2 minutes to Himanshu for rebuttal or what?
Yeah. I mean, rebuttal, I can only tell him one thing, sir. When you get your cataract operated, I promise you should do a femto. That's all. Try doing 50, 100 cases and then you will know what I'm saying. Unless you've tasted blood, you don't know what you're saying. So I would not like to say more than that. Maipal, would you like to add some words on femto?
No, my first say one thing. So this technology is being promoted by eminence-based surgeons, not the evidence-based. So the smart surgeons putting on a tie, so very good language, very nice setup. So it is eminence-based surgery, not an evidence-based surgery.
So the point you mentioned is always money. The problem starts there. And
I'm not mentioning money.
I am trying to tell you that it is not 100,000 more that you can charge. In fact, a surgeon is not making any great money when putting up a femto. Please understand, we are trying to go with technology. We moved when we went from extracapsular to phaco. There was a great amount of reluctance for such a long time. When we went from intra to extra, there is always, and we love people who like to say what you're saying. But I will only tell you one thing: try doing the first 100 cases and tell me your experience. After that, we can talk. Maipal, I want you to say something.
I think the rebuttal is over. Himanshu,
Yes,
2 minutes.
Yes,
yeah, Maipal could sum up. Yeah.
And we have to do the audience poll after this.
So the first thing that I'll wish to say is that this debate is an erroneous debate, because we are not saying that it is it's basically a complementary technology to each other. It is not that when you do femto you don't need a phaco afterwards, because part of the surgery is done by the femto. Now, whenever one is looking at something which is computerized and computer controlled, I really don't know, because whatever studies have come, none of them have shown, except in the early phases, an increase in the possibility of having a posterior capsular rent. And mind you, all these studies were before they were done on the Lensex, before the soft fit came in, where one would have areas of skip which are not there, which are not there at all in the liquid optic interface. I don't know which studies, because there are umpteen number of studies which have shown that there is a clear distinct advantage as regards the reduction in the amount of corneal edema, the first day corneal thickness, the aqueous flare, and the reaction in the anterior chamber, as also the endothelial cell count. Yes, I fully agree that the studies have also shown that by the end of 6 months, the difference is not statistically significant. But I have not come across any study in the recent literature wherein it has said that there is more corneal edema in femto, that there is more endothelial loss in femto, and that there is more reaction in femto. there is a clear, distinct, several studies which have shown that the amount of phaco energy that you have used is significantly reduced when you are doing a femto procedure as compared to a phacoemulsification, more so in hard cataracts. Now the question obviously is that even from a visual perspective, having a round circular capsulorhexis in no way can reduce the visual outcomes of a patient as regards the predictability. The answer to the question is that how much is the additional advantage that you get by spending that much of money, and the only thing that comes in the money. I think the same discussion was or will happen when you talk about microkeratome LASIK versus femto LASIK. And Dr. Harmans, you are yourself using femto LASIK, and cherry red spots are so huge in the intralays as compared to say a Visumax. The cherry red spots are also a historical thing when you are looking at a liquid optic interface where the pressure rise is very, very minimal. And I don't get any cherry red spots in those cases. So it is just a question of a technology that has evolved. I fully agree that there is going to be some time for people to accept it. And there are always more naysayers for any technology. And as Himanshu rightly said, but just to give you a fact, there has been the maximum growth. Cataract surgeries are growing by 3% globally, but the femto cataract in the same center growths have been more than 30 to 35%. So it is actually the patient's demand that is there. And I tell you that even if you talk to I distinctly on a podium, he said Mr. Bhardwaj, who was the governor of Karnataka, one eye was done with the normal and the other was done by femto. And he clearly emoted that the femto was far superior as regards the patient experience. At least in my practice, 80% of my patients are going in for femto. I don't even need to tell them that you need to go in for femto. They come and ask for it. And I have not seen a single patient from femto to a second eye that is not done. I'm really actually the problem, that real problem is that the comparison is of a technology in its infancy versus a technology which has matured. Femto is a technology that is still evolving. You are now getting Cassini's, you are getting the steep axis determination that is coming, taking care of cyclotorsion, getting new formulas for LRI, and you will get better outcomes with the LRIs now. It is not that the incisional keratotomies don't work. We are still doing nowadays, we're doing a lot of cataract surgeries in post-archaic patients. It is not that they didn't work. They are working, and a lot of patients have gone on to a hyperopic shift. So it is not that the thing is decaying. There is one study which said that the thing decays the LRI, but mind you, we have also done a study. The astigmatic correction is pretty good. So all in all, I'll say I think this debate will keep on going between people who have a femto and those who don't have a femto. And ultimately, at the end of the day, I will not say that this is a technology that is in any way whatsoever inferior, except that the fact that you have to make the investment in it. And the prices have come down of the technology, the prices of LOI have come down, and the number of patients adapting to it are significantly higher. Now, obviously, I am a wrong person to be taking up, because I obviously I am always a fan of technology, and I have always been having the first mover, whether an advantage or a disadvantage, but moving into technology when it has come of age. So I think that's all that I'll wish to say. But the proof in the pudding lies that all the ophthalmologists who get their surgery done from me, all, mind you, all have gone in for femto, except one of the ophthalmologists whom I only said because he had thick RK scars. And I said that, okay, it doesn't matter whether we are going it. And that he said, why don't you do a femto? I said, bhai, tere RK ke scars and there may be something, I don't want any complication. But over the last 5 years, all ophthalmologists that I have operated, and it's not that it is one ophthalmologist or two ophthalmologists, and even ophthalmologists who swear by SICS, even they have got a femto done from me. So that's all that I'll say. What it is. What is this audience polling?
We are going to have the audience poll once again, and I'm sure Mahipal has definitely will have an effect on the audience poll. We give.
This is a different question.
Yeah, okay.
So the question is, do we really need femtocataract surgery? And once again, we would like the response of the audience.
Is the voting on?
Yeah, the voting is on, sir.
Every doctor, Maipal, every general practitioner also, their parents and their own eyes, they choose to do this. So money is not the criteria. I'm with Maipal.
Where's the voting on?
Can we show the results?
Yes, it will flash up just in a minute.
Yeah. So very rightly said, sir, that it complements your surgeries, it helps in difficult scenarios, and it is something which is evolving. So very true. And let's have the results of the audience poll.
It's still the same, 79.
Okay.
Yeah.
Good.
Okay, we have seen it. It's 79.
Yeah, there's just an increase by 1%. So people are having their ideas very clear in their mind, and those
71-20.
So
it's 71-20.
My Paul के comment के बाद थोड़ा सा
8% has increased. 8% has increased.
No, Rajesh, 80-20 law always applies in this world for everything.
Yeah.
So once you know the 80-20 rule?
Yeah, what is that?
The rule is that that is what it says, that 20% of the ophthalmologists do 80% of the surgeries.
Okay.
That's an established fact globally.
After your comment, I think everybody is now tilted towards that side.
I had a comment, Rajesh, if I may.
Yeah.
Hi, Rajesh. I think the problem as it exists with femto today is that we are trying to talk about a technology that is non-inferior. Now, non-inferior is not superior. That is the problem. And unless we have something which shows its superiority, non-inferiority alone will not sell it. That, I think, is one of the biggest problems. And I think we need a little bit more work, little more evolution on the technology. And I'm sure there will be situations. It's showing superiority now in endothelial cell loss, and it is showing superiority in stability. But other than that, I don't think it is showing superiority in anything. It is only showing non-inferiority, not enough to go in for a technology which is 4 times more expensive. And I think that's one of the problems that currently is there.
I guess the point is that people think that it's a substitute to the conventional phacoemulsification. It's not a substitute. It complements your surgeries.
Correct.
And helps you in your in difficult scenarios. And I mean, it's just something which is an addition to improve the outcome. That is what it is. It's not a substitute to
Even Rajesh, I think there is another important point. There are certain group of people who buy the best. I mean, that's the one thing. When I go and buy a rice, whatever is the expensive is the best. So that mindset is there. So 10 to 20% of the population will go for whatever is the most expensive. You want to buy a shirt, which is the expensive, you will buy it. So those are the type of people. With the marketing, this technology is going to come up slowly, and we will be happy that it comes up. Because the biggest advantage is the cataract surgery drives the prices of all other surgeries in ophthalmology. So when I was charging 6,000 for the cataract, I was charging 5,000, 6,000 for glaucoma. When I'm charging 40,000 for the cataract, I'm charging 40,000 for glaucoma also. So the cataract surgery will set up a benchmark for every other surgery in ophthalmology.
So Harbans, you should thank Himanshu and me for increasing the price of cataract because today femto with trifocal I charge 1,60,000.
So please, you have a chance to charge $200,000 now, Harbans.
Yeah, this is what I'm telling you. No, I'm charging, may not be that, but 125.
For extra also you're charging 200,000. Chalo, let's stop femto.
Cataract surgery drives the prices of the all other surgery. That is the advantage. Now, even for the small things like entropion, we used to charge hardly any money. Now you can charge 25.
Sir, but we underpriced ourselves always in our life. Let me come to a very important point. We are strangers.
Himanshu, we are running out of time now.
Yeah.
And I think, Rajesh, I request you to introduce Rishi and the remaining.
Shashi, quietly.
Okay. So we have the next speaker, Dr. Rishi Mohan, who is well known in the cataract and refractive circle is the
He's the vice president.
अरे ये क्या लगाया अभी? Dr. Rishi Mohan is the director of MMI.
कोई बात नहीं.
He has been the president, boss.
This is actually some years ago.
Yeah.
It's a 5-year-old slide, I think. That's okay. It's essentially okay. There's nothing incorrect. So it's a non-inferior slide.
It's an evolving slide, actually.
Evolving. Good. So Rishi, go ahead. I think you're going to talk about dry eye and cataract surgery, right?
I'll talk about flax also. Sorry.
Great, great. So go ahead. All yours, Rishi.
Okay. So let me see. Right. So can you see the slides now?
No.
Oops. Now can you see my screen?
No.
Only you.
Wait a minute. I thought I had screen shared.
No, but did you open your PowerPoint
Here
first?
it is. Yeah, it's open. And
yeah, it started.
It's come now?
Yeah. Just make it full screen, please.
Is that working?
Yes, good, great. You can start.
All right. Okay. So you know the topic that when Lalit spoke to me, he's gave me a topic of is it normal to have dry eye after cataract surgery? And I started to think about it, and I thought, is it normal to have dry eye before cataract surgery? I think that is something that needs to be answered before you can answer something about dry eye after cataract surgery. So I changed it to, is it normal to have dry eyes after cataract surgery, to is it usual to have dry eyes before cataract surgery? And I think most of my talk is going to be on the fact that we don't really look for a dry eye in patients who are scheduled for surgery, especially if they are asymptomatic. And therefore, then the eye does not see what the mind doesn't think of. And so a dry eye is missed very often. And let's see what the data suggests. Now, let's look at the prevalence of dry eye in patients worldwide between those aged 50 and higher. And you can see that it varies between 5 to 34%, depending on where the location was, what the population characteristics were, and the diagnostic criteria, which may be different between the different studies. If we look at Asia, which is the region where we belong to, we find that the study suggests that the dry eye may be even more prevalent than it is in the rest of the world. And the incidence or the prevalence here is much higher than the prevalence in the rest of the world. Dry eye disease can reduce the visual quality and adversely affect the refractive measurements before keratorefractive and phacorefractive surgeries. Ocular surgery can exacerbate or induce ocular surface disease, leading to worsened vision and increased symptoms and overall dissatisfaction. And by treating ocular surface disease preoperatively, post-op visual outcomes and patient satisfaction can be significantly improved. In one study, upwards of 60% of routine cataract patients were asymptomatic, yet 50% of them had central corneal staining. In another study, the incidence of OSD in patients presenting for cataract surgery was over 80%, and in those who were asymptomatic, over 50% had either an abnormal tear osmolarity or an elevated MMP9 level, which means that they were either inflamed or hyperosmolar, meaning that they had dry eye. And we know that there are multiple studies showing that the impact of dry eye disease on topography, on biometry, on keratometry, on higher order aberrations is one of the major causes of disappointment in the postoperative outcomes. So once we have started to think of the fact that there is a dry eye, a little bit of a history of the patient, the ocular history, the medical history, the physical examination should reflect the examination for a dry eye rather than just for a cataract. And I was seeing the earlier presentations where the patient would come up into the OR, and many of us are busy surgeons, and we rely on some of the data coming in from our associates and our juniors. And sometimes some of these things can get missed. And one of the things that often get missed is the presence of a significant dry eye. The examination of the lids, slit lamp biomicroscopy, the observation of things like, the arthritic problems and the joint deformities, the dermatological diseases, the skin, the scalp, looking for rosacea, examination of the eyelids, and the slit lamp showing a host of features that can give away the presence of a dry eye. A general assessment of the lid borders, the debris in the tear film, the meibomian openings, the movement of the eyelids during blinking, conjunctival hyperemia, which is a good sign of inflammation. These are the things that one needs to look for, as well as the luster of the conjunctiva and the scarring of the upper palpebral conjunctiva. One can see the dryness or the xerosis just by looking at the slit lamp reflection, the presence of SPKs, which is present and seen by the use of dyes and filaments, the examination of the marginal tear strip, particulate matter, and mucus debris. These are all mechanisms to try and examine a dry eye. It doesn't take very long, but while examining on the slit lamp for a cataract, these are the things that should innately come in and get examined when we're looking at these patients. The tear meniscus height, now we have machines that actually help us do this. And a decreased tear meniscus height can give us a good idea about the tear deficiency. Fluorescent breakup time should be a part of our routine cataract evaluation as well as the interpalpebral surface damage assessments by the use of vital stains such as fluorescein and lissamine grain. The dye disappearance test is something that I use, and these are the patients where fluorescein is instilled. And once the fluorescein is instilled, one can examine these patients sequentially over the period that they are in the clinic. And if there continues to remain like here, even after 15 minutes, if there's still fluorescein in the eye, there's a significant issue with the amount of the fluid dynamics in that patient. The Schirmer's test is the other test that has to be done to look at the aqueous tear deficiency. So in summary, an examination, the measurement of the NI-BUT and the fluorescein BUT, the dye staining, the Schirmer's 1, 2, and the basic secretion tests, these should be done before we take these patients up for surgery. The ASCRS last year devised an algorithm in which they tried to identify and manage the preoperative dry eye before cataract surgery. And they used the following. They looked at the questionnaire, which they called the SPEED 2, the history, the physical and ocular examination, certain investigations, and then the preoperative OSD algorithm. And this is the SPEED 2 questionnaire, where they looked at the frequency of certain symptoms, such as dryness and grittiness, soreness, burning, and eye fatigue, the severity of the symptoms, which they again scored from 0 to 4, and whether they had these experiences recently or in the past few months, and whether they use eye drops for any lubricant, and whether they had any blepharitis or skin problems in the past. This was the algorithm, and the algorithm that they had showed a preoperative visit where a lot of these assessments were made, and then based on this, it was decided whether there was an OSD or no OSD, and whether this OSD was what they called visually significant or what they called non-visually significant. And based on that, it was decided whether to proceed with the surgery or to first treat the dry eye, convert the visually significant OSD to non-visually significant, repeat the measurements, and then take up for surgery. And I think this algorithm helps. We all have, over years, started to do similar things, but not broken it down and created an algorithm of this sort, which I think is extremely useful in managing our patients who are scheduled for cataract surgery. So we know that about 45% of the cataract patients suffer from dry eye before surgery, and this data is not Asian. So it's possible that we probably have even a higher number of patients who suffer from dry eye before surgery. So there are all these risk factors. The diagnosis I have already stated. So what are the pre-surgery treatment options? Of course, the first is lubrication, and we use that all the time. The use of anti-inflammatory agents is extremely important, looking for MGD and blepharitis again, and temporary punctal plugs and oral O3FA supplementation. These are all the strategies that are used in pre-surgery treatment options. The choice of lubricant, again, there are studies that have shown which are the best medicines to use. both hydroxypropyl guar as well as hyaluronic acid ophthalmic solutions are extremely effective. And as both these have excellent lubrication and water retention properties, and they promote epithelial cell migration and epithelial healing. CMC, either non-preserved or transiently preserved with osmoprotectants, also in the short term, is extremely effective. This, of course, is something which relates to sodium hyaluronate and its affinity to the CD44 adhesion molecules on the ocular surface, and how it helps epithelial healing in patients who have a damaged ocular surface. Cyclosporin, we are all aware of. It's been in use now for more than 15 years, and it is extremely useful for the reduction of inflammation in these patients who have a dry eye. If one looks at the visual function on the OSDI, studies have shown that everything from blurred vision, poor vision, reading, driving at night, using computer or machines and watching television all tend to improve over a few months if cyclosporin is used on the regular basis. After dry eye, after cataract surgery, again, the Schirmer's time and the tear breakup times over the first and second and the third months improved significantly in the groups that were using cyclosporin versus the groups that were just using normal saline as a control. So these studies have shown that anti-inflammatory activity is extremely important, and where cyclosporin is unavailable or not suitable for some reason, tacrolimus can be used to do the same job. Lifetigras is another anti-inflammatory that has come in. It is still not available in India, but it is showing promise in these patients. O3FAs, other than that one study by Penny Aspel's group called the DREAM study, which created some doubts about the use of O3FAs in dry eye, I think overall the bulk of evidence suggests that O3FAs are useful in the treatment of dry eye and should continue to be used in these patients. The other surgical treatments that I often use are temporary punctal occlusions. Permanent punctal plugs can be used, but you can wait till after the surgery to do that. Temporary plugs are usually extremely useful. And this little video clip here is just to show how a temporary plug is placed on the slit lamp. Technology has decided to convert this to a monochrome rather than a color video, which is what it was initially. So these are the small little collagen plugs that are there, which are dissolvable. They have a life of between 7 days to about 90 days, and they're extremely useful in short-term relief, because cataract surgery really you need the relief for 2 or 3 weeks till such time that the ocular surface can get restored after the cataract surgery is done. With an increase in awareness and the increasing use of premium IOLs such as multifocals, more physicians investigate for OSD now than previously, and that's a healthy trend. Even though it was brought about because of the use of premium IOLs, still it is something that I would strongly recommend. Similarly, an evaluation for ocular surface disease has become the standard in pre-refractive surgical workups. In the recent annual ASCRS clinical survey, even though 90% of the respondents, that means ophthalmologists, felt that mild to moderate dry eyes affected patient satisfaction in cataract and refractive surgery, but less than 10% were using currently available point-of-care diagnostic testing in their routine pre-op assessments. And that sounds very strange, that even though we are aware that there is a value of looking at mild to moderate dry eye, we are actually not doing anything about it. Is it normal to have dry eyes after cataract surgery? To come back to the original question. And if one looks at this, you can see that at 1 week post-op, almost 90% of patients in the phaco group and 92% of the patients in SICS group had a significant dry eye. But at 1 month, most of these had started to improve, and the incidence of dry eye after this cataract surgery was independent of the demographic and the anthropometric profile, the type of procedure, the time of microscope exposure, and the amount of energy. This dryness was largely transient in nature and showed a declining trend. What produces this dry eye? Injured corneal nerves, acute inflammation, the microscope light, ocular surface damage, and the earlier detection and adequate treatment for the ocular surface is critical to the patient's perception of the surgical outcome. Pseudophakic patients showed a 57% increase in prevalence of severe keratoconjunctivitis compared to controls. And this tear instability and epitheliopathy was found even at several months or more after the surgery. A recent study, 2019, coming from Hanyuda and Ayaki et al. The incidence of DED after phacoemulsification can be between 10 to 30%, depending on a number of studies, and again, resulting from the things that I'd already mentioned. The most commonly performed techniques of cataract surgery today are phaco and flax. And one can see here that in phaco surgery, the Schirmer score from baseline trips substantially at 1 month and improves to some extent by the 3rd month. Similarly, in the tear breakup time, it dips substantially in the 1st month and then improves somewhat up to the 3rd month. But it doesn't touch baseline in any of these studies. The direct contact with the ocular surface and prolonged exposure time, which affects the tear film and ocular surface function, does cast a little bit of a doubt on the femtosecond as far as the ocular surface is concerned. And if one can see, if a direct comparison that flax performs reasonably poorly, even in comparison to phacoemulsification, and one of the points that could have been a part of the debate that we had earlier when comparing the two techniques was what does it do to the ocular surface? And it stands to reason that anything in which there's going to be docking and the use of another machine is likely to impact the ocular surface more than the straightforward phacoemulsification. So the incidence of dry eye post-flax is even higher, and it's about 64% at 1 month. So both flax and conventional phaco can reduce the tear film status of patients in short term, affecting the ocular surface function. But the effects of flax on the corneal fluorescent staining and dry eye symptoms is greater than that of conventional phaco. So this is the changes in the Schirmer score after flax and the changes in the fluorescent staining scores after flax. And one can see again that these scores, even after 1 month, do not touch what were the preoperative levels. So we can say safely that flax has a higher incidence for corneal staining and dry eye symptoms compared to conventional phacoemulsification surgery. So in summary, it is common to have a pre-existing dry eye in patients who are undergoing cataract surgeries, and we must keep this possibility in mind and evaluate each patient before he goes to the OR. Preoperative treatment of dry eye is a proven way to limit the complications linked to dry eye and decreases the incidence and severity of post-op dry eye, as well as speeds the visual recovery and enhances the patient experience. The post-cataract surgery dry eye is almost universal, and that one must be kept in mind so that these patients should ordinarily have a lubricant as a part and parcel of their post-op regime. Effective management helps improve patient symptoms and signs, visual gains, and patient satisfaction after a well-done cataract surgery. So thank you so much. I hope that was something that would give us some food for thought.
Thank you, Dr. Rishi. It was an excellent presentation and very nicely highlighted the requirement for evaluation of ocular surface in cases who are, posted for cataract surgery. We will have the panel discussion in the end. We move on to the next speaker, and that is Professor Ritu Arora, who is the Director Professor at Guru Nanak Eye Center, a prolific surgeon, a very good academician, many publications and presentations throughout her career. She has been a complete academic person and a very eminent cornea and refractive surgeon. So I request her to start her presentation on the topic that is scope of conventional LASIK in today's scenario.
Thank you, Rajesh, for giving me this kind of an introduction. I don't deserve all that, but I think I have to be massacred. Therefore, I've been given this kind of a topic, and so I'll start sharing my screen. And just a minute. Just a minute, please. Can you see my screen?
Yes.
Go ahead.
Come now. You can go to full screen.
She was on full screen. Yeah, that's fine.
Yeah, it was earlier on full screen.
Yeah. So the topic which has been given to me is the scope of conventional LASIK in today's scenario. So it's almost similar to whether we do flax or we do phaco. So similarly, it's coming back to that. And with whatever experience I have, I would be talking about this. So just briefly, the refractive surgeries have evolved over the period of time, going on from RK to clear lens extraction and then to LASIK and SMILE and ICL. So, so everything we have in the current armamentarium, and we've seen all these things in front of us. So just to make sure that what do we really mean by conventional LASIK? So is the conventional LASIK simply meaning only a microkeratome assisted, or is it basically using microkeratome and femto together under the umbrella of conventional LASIK with respect to the SMILE coming up? And so whenever we analyze any refractive surgical procedure, these are the basic parameters to see whether the technique is fine. So it goes by efficacy, predictability, safety, complications of a particular procedure. So I'll first be going by the different reviews which have come up for LASIK versus SMILE. And this was a large review published in Ophthalmic Therapeutics, which said that the two techniques have comparable visual outcome in terms of safety, efficacy, predictability, though the recovery in visual acuity in SMILE treated cases was slower. And SMILE was found to result in less severe post-operative symptoms. 1 minute, I just have to minimize. Post-operative dry eye and faster recovery of corneal sensitivity. SMILE technique, though, is limited by the lack of cyclotorsion compensated system and option for customized treatment profile. So, how do I go to the next one? Yeah. So SMILE, basically, as we all know, it came in 2011. It's a flapless technique. And just there's only one platform on which we can do SMILE. And the VisuMax platform, which was approved by US FDA in October 2018, which says myopia for up to -10 power and myopic astigmatism up to -3 in power. And the total spherical equivalent of more than -10, not more than -10 diopters. But for the LASIK, which is FDA approved years back, the criteria given was that myopia up to -8 and myopic astigmatism up to -3, and total spherical equivalent of no more than 9 diopters. So the lower maximum spherical treatment in LASIK versus SMILE is because of the obvious need for a corneal flap. But the LASIK platforms, since it came up years back, they are equipped with cyclotorsion error compensation and eye tracking systems. So the SMILE technique also lacks the option of a customized treatment profile. So theoretically speaking, SMILE is inferior to LASIK in terms of refractive outcome. But the review also says that the visual outcome of SMILE was superior. When the SMILE came, it was superior to the first generation LASIK, but was inferior to the latter generations, which are like Alcon Contura and Vizix and Nidec EC5000. So the advanced generation of LASIK platforms, which can be used in wavefront guided or topo guided treatments, have advantages over the early ones. The other thing was that the slow recovery rate in terms of post-operative visual acuity in SMILE treated eyes compared to the LASIK treated eyes. SMILE further versus LASIK says, since there is a mechanical damage which occurs to the surrounding stromal tissue during LASIK, lenticle removal, during these lenticle removal and SMILE, there's a slower visual recovery. And there are multiple studies which are saying that there are trends towards undercorrection in myopia greater than -6. So maybe my next speaker, Dr. Mahipal, could talk about it. I do not have any experience in SMILE. I'm just going by what literature has talked about. SMILE also, the results in induced astigmatism results are pretty inconclusive. It has greater refractive power. The positive thing for SMILE given is that it has a greater refractive power for the correction efficiency as compared to LASIK in the peripheral cornea. So both techniques, LASIK and SMILE, they have great improvement in optical quality for a small pupil diameter, but SMILE has a better optical quality than the femto-LASIK in eyes with large pupil dia, and they have a better night vision with the SMILE procedure. Further, SMILE versus LASIK. Overall, LASIK has an advantage in terms of, as I said, significantly faster post-op visual recovery. SMILE not having that kind of a wow factor. There are lesser HOA inductions in SMILE group, and studies agree that SMILE results in less post-operative dry eye symptoms. But the biggest thing is that there are very few randomized controlled trials to compare SMILE and LASIK, and there are heterogeneous results. Also, the flaw being that SMILE, we have a single laser platform, while for LASIK, we have multiple laser platforms. So overall, if one looks at it, it's both the procedures equally qualify for efficacy, predictability, and all the parameters which are given, which I discussed before. So in conclusion, when we have SMILE versus LASIK, they are comparable for safety, efficacy, predictability in treating myopia and myopic astigmatism. They have similar effects on corneal clarity, along with some potential disadvantage of SMILE being that for greater refractive power correction efficiency in the peripheral cornea. So it is beneficial for cases with large dia pupil. The incidence of HOA and SMILE tend to be similar or even lower. But the disadvantage is that for patients with high astigmatism, treatment with excimer laser platforms are to be preferred because there is lack of cyclotorsional compensation available in SMILE platforms. There are no normograms for hypermetropia and cylinders. It is not fit for cases when we have to do refractive correction post-PK, post-RK, and no retreatments are possible in SMILE. So these are the disadvantages of SMILE vis-a-vis LASIK. Then we come to the next, another study which has come from Singapore, of course not so recent, in 2015, when it has compared the quality of vision in SMILE and LASIK. Its study says that in 3 months, predictability, safety, and vision-related quality of life scores were not statistically different between SMILE and LASIK. So overall, SMILE and LASIK fare same for all kinds of myopias. This is a system which I have been using since 2011. And now we come to what is conventional LASIK. So I was made to understand that the microkeratome LASIK is something which I have to stick to. So this is now, I have compared the results between microkeratome versus the femto flaps. And as again, a major review which has come up and regarding the accuracy of the flap, and the summary, it says that both femto and microkeratome are able to create accurate LASIK flaps, though femto flaps represent significant improvement in morphology, predictability, and safety. Femto flaps have, of course, the early generation femto flap had higher incidence of diffuse lamellar keratitis and transient light sensitivity syndrome. But now with the improvement in the femto laser technology, the incidence of DLK and transient light sensitive syndrome has gone down. And the other part, the epithelial defect and the flap dislocations are basically the complications for a microkeratome flaps. So the advantage of femtolaser flap over the microkeratin flap, which is non-negotiable, that there is a decrease in flap imperfection, like that you don't get buttonholing of the flaps. There is less time and effort in flap preparation. There is decreased risk of infection. There is lower peak of intraocular pressure during the procedure. There is less induction of dry eye and less effect on corneal sensitivity. Further, when one looks at microkeratin LASIK flap and femto-LASIK flap, the design of both the flaps is different. In microkeratin, the flaps are meniscus shaped, while in femto, they are the surface parallel direction. Also, and the different comparative studies have said that the flaps created with femto-LASIK present a lower deviation from the target thickness. So they are very much within the intended thickness, and the femto flaps have more uniform flap thickness across the flap diameter. Femto flaps, they have the opportunity, whenever you are doing it, and in case you get an incomplete flap, you can, opportunity of continuing the lamellar flap creation after loss of suction. While in case of microkeratin, if you have incomplete flap, you have to abandon the surgery. So femtosecond flap creation produces less and more predictable change in corneal biomechanics. Thickness in the flap created with femto, as I said, is more accurate, more reproducible. And a lot of these studies have actually been done comparing using Moria microkeratin. And femto flaps are thinner, reproducible. So basically, the flap architecture, flap stability of femto flaps are far superior to the microkeratin created flaps. But does it really matter in the long run? That's what we've got to discuss. In a meta-analysis which was studied in a Cochrane study group, which just came in 2020, it says that despite the significant difference in the morphology and flap thickness with respect to precision, the femto-laser microkeratin flap, they have no clear advantage in terms of efficacy, because both the groups invariably have the uncorrected distant visual acuity as the 2020. The accuracy of correction in both the groups is within plus minus 0.5 diopters. There's safety of correction in both the groups to the same level. Femto-laser microkeratin flaps, they induce fewer aberration because of the, as I discussed, the shape of the flaps. And safety increases as the flap thickness and the standard deviation decreases. So overall, I've already discussed this, the advantage of the femto flap over the microkeratin flap. And of course, the certain issues which are specific only to femto flaps are DLK, complications related to femto flaps in terms of bubbles in the anterior chamber, transient light sensitivity syndrome, and rainbow glare, which are again specific only to the femto flap. And in a randomized control trial, when the femtosecond laser versus mechanical microkeratin flap, of course, it's an earlier study in 2007, it says that the method of the flap correction did not affect the visual outcome during the first 6 months after LASIK, although corneal backscatter was greater early after bladeless LASIK than LASIK with mechanical microkeratin. But patient did not perceive a difference in vision, whether femto or mechanical microkeratin. In a Cochrane database of systemic review, which just came in 2020, where they have compared the effectiveness and safety of mechanical microkeratin versus femto laser in LASIK for adult with myopia, the authors have concluded that regarding the visual acuity outcome, there may be no difference between LASIK with mechanical microkeratin and LASIK with femto laser. Dry eye and diffuse lamellar keratitis are the likely adverse event with mechanical microkeratin and femto laser. The evidence is uncertain regarding corneal haze and epithelial ingrowth, but there are limited number of outcomes reported in the whatever trials had been included, some of which are potentially significant in bias. So they said it is difficult to draw a conclusion which is superior. So ultimately, I would just like to say that femto LASIK has these advantages, which I've already talked about. It has a disadvantage of having an increased cost and larger physical size and having to have two lasers in the same OT. So if I really have to compare conventional LASIK versus femto LASIK, uncorrected visual acuity is same, predictability is same. As far as the flap thickness, the range given with microkeratome, there's a wide variability, but one can go minimum to 90 micron. Similarly with femto, you can go minimum to 90 micron, but the variability is lesser. The adverse effect with microkeratome more pronounced is dry eye, but with femto, it is DLK, corneal haze, TLS, and rainbow glare. Complications with microkeratome may be just free or incomplete flap, buttonhole, and epithelial erosions. And with femto, there are vertical gas breakthrough, anterior chamber bubbles, and opaque bubble layer. And of course, the big advantage of microkeratome LASIK is that it is fully reusable after dismantling and sterilization. And of course, there are so many other studies where it has said in the long term, there has been not much difference in the vision, which both the groups had. As far as my experience, for the past 11 years, I've done more than 3,000 LASIKs. We've treated refractive errors between minus 0.75 to minus 9. Cylinders I've treated between 1 to 5 diopters. I've used plano, aspheric, and wavefront platform. And my results, in 99% of the cases, we had vision more than 6/9, and in 98% vision more than 6/6. The only complication I got in my 3,000 cases, including my learning curve, I've just had 2 incomplete flaps. Again, they were due to some, not my problem, not my fault, I would look at it, and 1 toxic interface syndrome. And I've only needed to do retreatment only in 2 cases. Rest, I'm very happy with this kind of a system. And this is the way we work up with the op scans pre and post. We can get a very nice central ablation. And we do wavefront for every patient and do the wavefront guided ablation. We brought out publications regarding the refractive outcome of wavefront guided LASIK and wavefront guided PRK in cases where pre-existing higher order aberration. And we concluded that wavefront LASIK and wavefront PRK have similar efficacy, safety, and predictability. There was another publication which we got out regarding the comparative evaluation of higher order aberration and corneal asphericity between wavefront guided and aspheric LASIK. And we concluded that aspheric LASIK induced significantly less change in higher order aberration and maintained corneal asphericity better than the wavefront guided LASIK at 6-month post-op. So is conventional LASIK, the question to, is it on its way out? I would just like to say, yes, femto does have its core over conventional LASIK because of the flap architecture. But if I'm short on my funds and I do have this LASIK, it still serves my purpose because old is gold. And this being an old technology, safety, fast track, track record is very well proven. More than 25 years of track record is there. Ours being the only state level medical college, because not in all medical colleges, except for few autonomous institutions where you have the facility of femto LASIK and frequent change of technology. So ours is the only state level medical college in the country which has this kind of a LASIK. And there are difficult procurement systems, and we have to honor the AMC, CMC clauses and the government rule. So if I have the conventional LASIK, though I'm trying to get upgraded, a conventional LASIK, I would say that my purpose is solved. And there is learning and it is essential because at least all my residents are very well trained for the refractive surgery workup, and they get hands-on on the refractive surgery, and they learn the nuances of refractive surgery. So is it really on its way out? No. And it definitely has its economic aspects to it. So many thanks for your patient listening. I hope I made sense out of whatever I said. Thank you very much.
Thank you, ma'am. It really made a lot of sense, and you very nicely highlighted the facts and the scenario wherein you can easily have a good outcome even with a conventional LASIK. Although you highlighted the advantages of femtosecond LASIK as well. So can you just stop sharing, ma'am?
Yeah, just.
So now we move on to our next speaker and have a panel discussion in the end. And the next speaker is Professor Mahipal Sachdev, who is the Chairman and Medical Director of Center for Site Group of Hospitals. He is a renowned ophthalmic surgeon par excellence. He's the president of AIOS. He has been awarded Padma Shri. He has so many things that I'll have to say in order to complete his introduction. Numerous things. So instead of doing that, I would request him to start his presentation and teach us something about how LASIK to smile, the evolution has taken place. Professor Mahipal Sachdev.
Thank you very much, Rajesh, for the kind words. Can you stop the screen share? Yeah. I'll be talking about smile, and I really didn't know that it was a debate, but anyway, I'll just to take up from where Dr. Ritu said, whom I've known for several years, ever since the MBBS days. I think India is a country where the bullock carts and the airplanes will all go. So there is no obviously there's a great impact of the prices to a lot of population, and LASIK in itself is a very good procedure, and it's a gold standard, I would say, for refractive surgery, and it has evolved over the years. But as was said earlier by Himanshu, there are going to be upgradations, and everything will have its place in the sun and will have its years of glory. Having done LASIK and then switched on to the femto LASIK, I think ours was the first unit in 2005. And that time the interlace was at 60 hertz. So that obviously when you looked at it starting from 15 going on to 30, 60, 150, now you have 500 and higher and things like that. There is a lot that has changed vis-a-vis the laser procedure from the femto perspective, where DLK is really a thing of the past. You don't see any DLKs and things like that, and the tightness of the flap thickness has also increased. Now, when we look at LASIK going on to smile, so from the blade LASIK went on to the femto LASIK. And what I will just wish to say, as Charles Darwin said, it is not the strongest of the species that survive, nor the most intelligent that survives. It is the one that is the most adaptable to change, that lives within the means available and works cooperatively against common threats. So what I'll just wish to say is that for me, as for everybody else, change is constant. And I think life has taught me that it is a treadmill and you have to keep running to be even at the same place. It is going to keep on evolving, and the technology evolution is much faster than it was before. The speed at which technology was changing is much exponentially higher. And just because Dr. Ritu would have obviously searched the literature and things like that, and she talked that there is the one platform on Smile. Dr. Ritu, Zemer has got CE certification, so has Schwind got, and J&J is on phase 2 clinical studies in FDA, and so is Alcon on phase 1. So as things stand today, all companies across the globe which are big in refractive surgery are working on the platform of lenticule extraction. Now, when you look at the lenticule extraction, obviously the goal for a person is to be without glasses. And this actually is showing you about contact sports. So when you're talking about contact sports, that is something that was not really highlighted by you. And what the patient actually wants is good visual recovery, fast recovery, minimum dry eye, minimum post-operative care that is required, minimum complications, and a stable refractive correction. I just wish to tell you that again, I don't know whom, what study at which year is being quoted about fast recovery. Mind you, all our patients who undergo smile after you have learned the technique of smile where there isn't manipulation in your removing the lenticule are 6 or better the next day as they are in LASIK. So I think this is the only final myth that is remaining, that the recovery of vision is slower in smile as compared to LASIK, whether you are talking about blade LASIK or femto LASIK. Now, the surgeon, obviously, what you rightly pointed out was that femto LASIK takes the level of safety to a much higher level, as also the predictability of the flap and the architecture of the flap. That is the most important thing. I am personally involved in the development of the new femto of one of the multinational companies, and we are testing the geometry of the flap, and it is within plus minus 0.1 millimeter. That means that if I want a 8.2 millimeter flaps, I will get between 8.1 to 8.3 with a very tight curve that is there. And the thickness of the flap, if you measure on the OCT, also within, there may be an aberration where you quoted a 73 micron. It is normally within plus minus 10 to 20 microns of difference in the flap thickness. Now, the other important thing that the surgeon wants is that the laser performance should be independent of the external environment. This is one thing that I will discuss more in detail between when you are talking of a femto laser versus an excimer ablation. Now, one important thing that kind of clearly differentiates a flapless procedure from a flap is the flap related complications, which I think in a LASIK procedure, I really compliment you for having only 3 such complications. But what has been described in literature is that you could have flap stria, you could have flap dislocations, you could have amputations of the flap, you could have flap button holding tears, etc., etc. So flap related fiascos which are there are the maximum complications. The lasers have evolved over time, and the complications of decentrations, cold spots, etc., and are much less that is there. Now, the other important thing, as Dr. Rishi pointed out, is that dry eye is not something that can be neglected, and there are a lot of patients who do complain of dry eye. So as the evolution has happened from conventional LASIK to the femtosecond, where you need one femtosecond plus you need an excimer laser to reshape, to a single step procedure, which is being done on the Visumax platform, a minimally invasive and innovative procedure which creates the complete lenticule, and there is a small access in one step only. Manual tissue separation through the small incision happens, and you extract the refractive lenticule through the small incision. Now, there are 4 steps that you undergo, that a patient undergoes. The first step is the bottom of the lenticule. So that is wherever you want to do, that is the bottom. The second would be the side cut. Third will be the cap. This is the cap, and fourth would be the side cut. So these are the 4 steps which are there. Let me just show you the procedure. And mind you, Dr. Ritu, this is totally an unedited video, and you can see that this is being done. The time taken, one of the important things that when you do a smile procedure, whether I am doing -1 or I am doing -10, the limit may be different in FDA, but the limit in India is -10 of sphere and -10 of cylinder. So actually, if you go on to a spherical equivalent, you can go up to 12.5. So these are the 4 steps that have happened. This is the OBL, which shows that there is the bubble layers that have been created, and this is a uniform thing. You go in vertically, and then you are going in horizontally on top of the lenticule. And now the second stage is going to the bottom of the lenticule. Now, once you have gone there, you just use a blunt spatula to go in and create this layer. It is reasonably effortless to create this layer if you have optimized the setting of the laser. An increase in resistance is because you have not optimized the laser, or there is dryness in the surface at the time of applanation. Now this is, you have gone in above, now you are going in below, and there are several signs which I need not discuss in detail to find out that you are in this proper plane, but suffice to say that you can see that there is a lift of the lenticule that is happening right here, and you have to just go ahead and separate it from both the sides and leave a little bit till the right till the end, and then you remove by using a forceps. So being a corneal surgeon, Dr. Ritu, you can easily see that this is the least intrusive onto the cornea. You are having a 2 mm side cut and instead of a 22 mm side cut. So this is the lenticule that has been removed very well. So the one of the biggest advantages that LASIK versus SMILE is that there is no flap. So you don't have any chances of flap displacement. There are no chances of buttonholing. There are no chances of free flap. And microstria, epithelial ingrowth, DLK, etc. These are the problems that you don't have. Now, the other important thing is that the duration of the treatment is independent of the power corrected. That means that if I have to correct a -9 versus a -1, it is only the depth at which I am creating the two lenticule separations. That means the posterior lenticule and the top of the lenticule. And it is going to take me for an optical zone of 6.2 only 23 seconds. So it is not that if I have a larger refractive error, I have to spend more time. So this gives superior workflow. And what is also very, very important is that it is not at all influenced by environmental factors. There is just the focusing mechanism which has less standard deviation than a burning mechanism. So you focus at a particular point. The stromal bed hydration does not matter. The humidity and the temperature of the operation room does not matter on the outcomes of the procedure. So the advantages are that it is flapless, it is all femto, and it is a single step procedure that you have. Now, when you compare LASIK or femto LASIK to the flap, to the SMILE that you are having, the beauty of Visumax is that it is a curvature. That means that the applanation is right on the curvature of the cornea versus the flat applanation that you create whenever you are doing a microkeratome or a femto laser based procedure for a flap, and the amount of pressure that rises there is much less. This is verified by the fact that even though suction is on, the patient continues to see the green blinking light through the procedure till the first pass of the laser has happened. So the pressure is not significantly raised, and there is no loss of vision during the procedure. And as you can see on the cross section, there is a gentle suction which is all through, and that is at the limbus. So it is at the cornea, more on the cornea and slightly on the limbus. There is a low suction pressure, minimal applanation, minimal IOP, and there is no IOP increase, and there is no subconjunctival hemorrhage. The same as I was talking in catalyst, which is a liquid optic interface. So you don't have, and you don't need to have any consumable gases or tight environmental control. Now, what you said is absolutely right, that as regards the refractive outcomes, the efficacy of LASIK and SMILE is very good. As regards the predictability, also you can see that in some studies, SMILE has fared much better than LASIK. But what is very important, which you also agreed, is that the higher order aberrations, and I'll give you the reason, several studies have shown that there are fewer total higher order aberrations that you get with SMILE as compared to the excimer laser. Now, the biggest thing that you do when you are doing an excimer laser is that, as you all know, that the cornea is a biconvex structure. And when it is, you have the convexity here, it is only in the center of the cornea that you get actually a round spot shape and an even distribution of the excimer energy. When you go on the slopes, the elliptical spot shape is there, and only 26% of the energy absorption is there. And when you are not doing an aspheric profile on an excimer laser, there is an induced spherical abrasion that you get. But the SMILE is an exact aspheric lenticule. That means that it is an aspheric lenticule. I agree, it is not customized, but a lot of us and almost all of us in the excimer laser technology have moved out on the Q value and on the asphericity of the cornea to get the aspheric ablation rather than a particularly customized abrometric ablation, because there has been found to be, we started these ioptics in 2000, and there was no significant difference or no advantage, rather the results were slightly inferior when you did an abrometry based ablation. Topography based ablation for irregular corneas has a great place for irregular corneas. Now, studies have shown that there was a statistically significant difference in the horizontal coma that has been induced. There was higher horizontal coma that is induced in the femto LASIK as compared to SMILE. and the cutting of the flap itself induces abrasions. These are our studies done out of our Baroda center. If you look at the point spread function between femto-LASIK and SMILE, you can see it is much better. The quality of vision is better. Post-operative inflammation, several parameters have been studied. And if you look at the corneal innervation of the nerves, you are, as you all know, that the corneal nerves come from the periphery and then arborize. And if you are cutting at 8.5, so first thing is that you are cutting at 8.5 or 9. When you are doing a SMILE, you are doing it at 7. So by that time also there is a deep arborization, but the superficial nerves do not get cut except at this 2 millimeter junction. While in LASIK, you have the whole 22 millimeters that is cut, and confocal microscopy has shown very clearly that there is less distortion of the corneal nerve. Dry eye is conclusively proven. I don't need to go into that. It is very clear that tear film breakup time, osmolarity, OSDI is much less impaired. Corneal sensitivity comes back much faster. And what is also very, very important, I am really again impressed by your lack of retreats that you have done, but I have also been doing since 1998, I suppose, the laser vision correction. But there is always a known regression that happens whenever you are doing a LASIK procedure. And the studies have shown that enhancement rates of SMILE are much lower as compared to that of LASIK. Yes, Dr. Ritu, there is a slight tweaking of the nomograms that all of us do depending upon our results of doing a slight overcorrection in high myopes and specifically in younger patients by about 5 to 10%. So this is the enhancement rates that have been said. Now, yes, what you said is that you can't do a SMILE on SMILE as things stand today, but you have a circle scan in which if you are seeing in the right side, you see that the cap which was there actually gets converted into a flap. Okay, so you can see that we are going at the same parameters that we had. We make the inner cut and then we make the outer cut. And you can see this is like a donut, and you can easily lift up this flap. So there is no issue. Either you can do a surface ablation. Yes, I agree. A SMILE on SMILE will be a reality maybe in the next 3-4 years or 2 years. But you can see here where the SMILE, you are seeing where the earlier lenticule had been taken off. And now this cap has been made into a flap effortlessly. And then you use an excimer laser to do the correction that is required. So it is not that if you are to retreat a patient or SMILE, you cannot retreat a patient. But what is very, very important is that SMILE enhancements are much safer than LASIK redo, because when you do a LASIK redo, if you are specifically using a microkeratome, you will not be able to cut in the same plane and you can have sliverings. So what majority of us do is that we relift the same flap, and it is well established that relifting a flap gives you an excessive incidence of epithelial ingrowth rather than if you have a fresh cut. So if you're doing a LASIK on top of a SMILE, it is a fresh cut and there is the chances of epithelial ingrowth are much less. Now, another important thing which I think a large cross-sectional study will prove beyond doubt, but there are several studies which show that the biomechanical weakening of the different options that are available are much better that is there in case of these SMILE procedure. I'll just discuss that again. Now, as you rightly said, that when you are looking at a femto flap versus a mechanical keratome, you cannot retreat if you lose suction at the same time in a blade keratome, while you can do that in a femto-LASIK. And the same thing is that you can do it when you are doing a SMILE. Now, if you are losing your cut at the initial 10%, you can restart from the beginning. If the lenticule cut is more than 10%, then you have to convert it into a femtosecond laser or wait for 2-3 months and do it again. If you are having a loss of suction during the lenticule side cut, you can repeat for the side cuts by decreasing the diameter by 0.2 to 0.4. And if it is during the cap cut, you can repeat from the cap cut. I'll just show you all these. And during the side cap cut, you can repeat the cap cut only by decreasing by 0.2 to 0.4. Now, I'll just show you this. You can see this is the posterior lenticule cut that is happening. You lose the suction here. So there is nothing I can do, but I can immediately create into a femtosecond flap and go ahead and do it. So this is more than 10% of the first cut. I make it into a flap. Now this is suction loss during the anterior lenticule cut. So this was an astigmatic cut. If you saw that this was coming like this, and you can see that this is the first lenticule, the posterior of the lenticule. This is the side cut that is happening. And then you can see that there is a suction loss that is tending to happen here. Can you see this fluid coming in? Ideally, one should just stop it. There's no problem. And you can just go ahead, redock. You can see you can redock. And I'll just show you, you can redock and again recut, but there is some disalignment which is there, but doesn't matter. And you can see that I won't go into detail. It is just like any other smile procedure that you can do. Like in a femto flap, you can recut. So you can also recut in the smile procedure. And I'll just go forward and you can see this is the lenticule. This can be easily taken out. And this is the end of the procedure that you have. Now, let us see in this particular case. Here you can see that again we are tending to lose the suction at this particular point, and you can see that this is a suction loss which is happening, and I am trying to get at the edge of the cut. So I should leave the suction at that time and actually recut, but you can see that despite trying, we don't get it. So all that I am doing in this particular case is to convert it. This is the cut that was there, but I was not able to identify. I do it as a circle scan. And you do it as a circle scan, you lift the flap, you lift it as a flap, and the lenticule that had been created, you can see, you can take out this lenticule and the patient is going to get good results that is there. Now, one thing is there, maybe smile is a little later technology, but there have been only 7 case reports of ectasia following smile in case of normal corneas, and we have also reported 1. What is important is that the biomechanical strength of the cornea is supposed to be better than that of LASIK, which is there, because if you are doing a PRK, as you all know, Cynthia Roberts and others have shown that the anterior corneal stroma is far stronger than the mid stroma. Now, when you are doing an ablation or you are making a LASIK, you are cutting the anterior stroma and also doing an ablation right in the anterior stroma. While in a smile, if you do it at 120, 140 cap, you are taking the lenticule from the top of the mid stroma. And therefore, there are several studies. It is statistically, in some studies, significant, in others it is insignificant. But one thing that has come out is that if you are doing smile extra versus LASIK extra, that means you are using a cross-linking along with that, the smile extra eyes behave much better than a LASIK extra eyes. Now, quality of life after refractive surgery, smile versus femto-LASIK, higher satisfaction trends and long-term quality in patients undergoing relaxed smile in comparison to femto-LASIK. These are several studies. Actually, in Eye Foundation, there has been a study which has been done, and the patient always reported in 93% of the cases, one eye done by Contura and the other eye done by smile, that the smile eye behaved better and higher order abrasions were better, as also the refractive outcome was better. Now, what you are talking about, I agree, there are 2 problems which are there in smile. One is the cyclotorsion and the other is the lenticule geometry that you have. So hyperopic lenticule geometries are being worked on, and commercially this should be available soon. Now, when you are looking at the astigmatic correction, Dr. Shri Ganesh has rightly described that you need to mark like you mark in a toric IOL, the 0, 180 degree, and you can turn the patient interface after docking so that the cyclotorsion compensation is there. But mind you, all new machines, including by Zeiss, are going to take care of the cyclotorsion. And majority of the new machines on which we are working, I myself have the hyperopic correction, and the compound numbers, all types of numbers can be treated with them. That is something which is very, very important. And also you have been able to use the stromal lenticule for several things. People have used it for keratoconus, for cross-linking. You can even use it for putting like a ring, etc. That is there. So the advantages of smile are biomechanically stronger cornea, conservation of the corneal nerves, less induction of dry eye, superior refractive predictability and stability, superior surgical alignment and having an exact aspheric correction. Now, one thing that I forgot to tell you is that if you are doing a lenticule of 6.2, if you do a post-op topography, it will be 6.2. But if you are doing an ablation of 6 or 6.2 on an excimer, and if you do a topography, the effect will be only on 5.5 to 5.7. So the exact, that is why what you quoted in a study, because dark light conditions, because it is a bigger lenticule that you are taking out with the same amount of tissue sacrifice, the quality of night vision is much better in these particular cases. So finally, I will just wish to say that the evolution of refractive surgery is heading closer to the preservation of corneal biomechanics, and SMILE is the latest technique to follow this pattern of preserving corneal biomechanics. Now, basically, I wish to thank you because you didn't raise the issue of retained lenticule and all. Now, these are far and few and between, and these are complications that people had in the earlier phases of learning. It is very, very rare for you to have a problem in the dissection of the lenticule, and it's like a surgical technique that you do, that you need to be careful about calibration of the machine, setting each individual machine, and doing a good surgical work that is there. Another important point that the refractive surgeons are aiming to achieve is an abrasion-free treatment. And I think, again, as I said, for femtocataract, for SMILE, almost all my patients, which is more than between 80 to 90%, except for hyperopes and thin corneas, where I do a surface ablation, I do with SMILE. And that is something that obviously all big refractives, big means high volume refractive surgeons, if they can afford it, they have all switched over to the SMILE technology that is there. And I would just wish to say that, yes, we have done SMILE in almost all VIP patients. And I think having the access to a femto LASIK, blade LASIK, and to SMILE, it is something that we prefer to advise to almost all the patients for the various benefits that I have told you. Thank you very much for your kind attention.
You, sir, for very nicely and comprehensively covering the topic of SMILE, and we will definitely have a panel discussion later. We move on to the next speaker, and that is Dr. Rishi Swaroop. And he is a very well-known cornea and refractive surgeon working at Swaroop Eye Center, Hyderabad. And he has been actively involved in academics and clinical works. He has many papers. He has chapters in textbooks. He has many presentations in instruction courses and free papers worldwide. So without going much into it, we request Dr. Rishi Swaroop to share his slides on the topic of post-refractive surgery, which lubricant to use and why. It's a very pertinent topic, very important topic, which most of us keep thinking about. So let's see what Dr. Rishi has to talk about it.
Thank you, Dr. Rajesh. At the outset, I'd like to thank AIOS, Dr. Lalit Verma, Dr. Rajesh Sinha, and all the organizers for involving me in this wonderful webinar. The topic given to me is post-LASIK dry eye, choosing the right lubricant. So what I'm going to try and do is touch upon the mechanisms of post-LASIK dry eye, and then go on to how to select your lubricant, which is the main focus of the talk. Dr. Rishi Mohan made my talk a little easier by focusing on some of the basics. And I'm just going to take it forward from there. So when you talk about post-LASIK dry eye, it's not just LASIK, any corneal refractive procedure. Probably the most common complication of any corneal refractive procedure is indeed dry eye. And it's also been well documented that it's actually one of the most common causes of dissatisfaction after LASIK. There's not one cause. We know that there could be multiple reasons that patients can have post-LASIK dry eye. So it's multifactorial etiology, and it is a wide spectrum problem. And why does it happen? Like I said, there could be multiple causes. Corneal denervation, Dr. Mahipa Sachdev nicely alluded to this in his talk. You're cutting corneal nerves whenever you're making a LASIK flap. Even when you're doing a smile, you're damaging them. Even in surface ablation, you're doing some amount of damage to these superficial nerve fibers. There is some sort of damage to the goblet cells, especially when you're applying a suction cone or applying a microkeratome with suction. There is an alteration of shape because of the ablation of the cornea, which can again cause a problem. There is inflammation associated with the procedure. There is tear hyperosmolarity, which is created postoperatively, and the vicious cycle of dry eye kicks in because of one of these factors, and then it self-perpetuates to worsen the problem as time goes by. So reduced basal, the abnormalities in the tear are that you're having a reduction of both basal and reflex tearing. There's a reduced blink rate because of probably then reduced neural feedback, increased osmolarity, reduced breakup time, reduced surfacing of the tears, again because of alteration of the corneal profile, because of denervation, inflammation, and shape change. So when you're talking about corneal denervation, it's either caused by the mechanical damage by the microkeratome or because of the photoablation by the laser, or even because of a femtosecond cut. So epithelial, subepithelial, and superficial stromal nerve plexus are transected at the edge of the flap and at the interface, resulting in a more pronounced effect in the central cornea. The surgical destruction of the nerve endings of the subepithelial plexus produces hypoesthesia. With a decrease in stimulation, the feedback loop is affected for the lacrimal gland, and thus also there is an aqueous lacrimal deficiency. And because of this denervation, there is also reduced blink rate, which results in an evaporative dry eye as well. So you have both an evaporative as well as a aqueous deficiency dry eye in these situations. There's a specific entity which has also been described with LASIK called LINE, which is basically LASIK-induced neurotrophic epitheliopathy, which is basically a transient dry eye, which you often see in LASIK patients. And it can also affect the vision, especially the central cornea is having punctate epithelial erosions. Typically starts 1 to 2 weeks after LASIK and may disappear after a few months as the nerves grow back into the flap. And this has been published in literature. So this is one of my patients. You can see the brown arrows are clearly showing the LASIK flap outline, and you're getting these central confluent SPKs. And if they come into the visual axis, they can actually affect vision, and patient would think that there's a problem. I'm sure all of us who are doing large volumes of LASIK have seen patients like these. You just need to give them lubricants and reassure them, and with time, they often become normal. And it's not necessarily that it happens in both eyes. Sometimes it happens only in one eye for some unknown reason. What are the risk factors for post-LASIK dry eye? Age is probably one of the things. So various demographic factors are there. A higher age, they're more prone for intraoperative epithelial damage. Gender, females are more likely because of hormonal reasons. Race, it has been shown that Asians are more prone for post-LASIK dry eye, probably because of the tighter fit of the eye and a smaller eyes. Pre-existing dry eye, of course, these patients will have a worse dry eye postoperatively. So it's important to identify these patients preoperatively by a good preoperative evaluation and then treat the dry eye. Look for systemic conditions like thyroid eye disease, diabetes mellitus, and of course, if they are smokers, please do warn these 3 patients about possible post-LASIK dry eye, and if possible, discourage them from having a LASIK. And of course, air conditioning, pollution, excessive use of digital screens, which is now pretty much universal, are all environmental factors which can predispose. So patients who are habitually going to be doing these or living in these conditions, you have to warn them about this possibility and of course, counsel them appropriately. Higher refractive errors have also been shown to be a risk factor, both because of deeper ablations and also because of more alteration of the corneal profile, because of which the tear dynamics are altered. Again, deeper ablation comes into the same thing. Hyperopic LASIK is more prone for dry eye because you're cutting more of the peripheral nerves, ablating more of the peripheral nerves because of the hyperopic zones. Also, the flap diameter tends to be larger in hyperopic LASIK. Hinge again plays an important role. More than the position of the hinge, it's the width of the hinge that matters. And of course, the wider the hinge, you'll end up The smaller the hinge, you'll end up cutting more nerve fibers. So that is basically how it plays a role. Which type of laser vision procedure? I think this has been elaborated nicely in the previous talk. So LASIK will definitely have more nerve damage compared to a surface ablation or a SMILE, and it has been amply shown in literature that it is certainly the worst of the lot in resulting in post-refractive dry eye. So what is the management? Of course, you have to do environmental modifications if there are environmental factors, blink more. But mainstay of treatment, of course, remains tears. And that's what I'm going to spend the next few minutes on. Other things which could be done is use of a temporary occlusion. A nice video was shown by Dr. Rishi Mohan. So we know that most of the post-LASIK patients have a temporary dry eye. And if you can tide over this time by giving them a temporary or a medium-term occlusion of the punctum by using a collagen or a similar kind of a plug, it may be a good idea to do that so that the patient in the immediate and medium post-operative period is not forced to put very frequent lubricant drops. Of course, if there is a meibomian gland dysfunction, that has to be addressed ideally preoperatively, but sometimes even after surgery, this can show up possibly because of the preservatives in the tears, the meibomian glands get inflamed, and you have to address that. There would be an element of possible treatment with nerve growth factors, but these are very expensive and not readily available. We must look out for dry eye mimics. There are several other conditions which can present with symptoms and signs very similar to dry eye. And one must look for these and treat those specifically. For example, if the patient has a nocturnal lagophthalmos, you will have SPKs in the inferior part of the cornea. But unless you address that, you're not really going to give this patient some treatment. Omega-3 supplements may help, but their role is controversial. Vitamin D, all these have some mention in literature, but we really don't know how much they help. Scleral contact lens can be used in very refractory cases to improve the ocular surface. Immediately, the patient gets a lot of relief. If nothing is working, just reassure the patient and just wait for some time. Don't call the patient every few weeks. Give them some time. Tell them it's going to take 2 to 3 months. Come and see me in 2 to 3 months, and then we'll take it from there. And usually, most of these patients will be okay if you give them time. Counseling is key. Tell them before itself that this is going to take time. Don't worry. I am there. Time will heal everything, and that usually does. Like I mentioned, the mainstay of treatment is lubrication, and it is really it's a no-brainer because it's safe, it's effective. An ideal lubricant is one that spreads effectively, quickly, and evenly without causing much of blurring. Remember, these are patients who have had a refractive procedure, so they want to see well. And it not just makes the patient see better, also improves the signs of dry eye, and of course reduces friction between the lid and the conjunctiva and cornea. So how does it work? Ideal lubricant should reduce the tear osmolarity. It should increase lubrication. It should replenish the constituents of tears that have reduced because of the procedure. And if there are inflammatory cytokines, these should get diluted. So you would ideally want something which has a neutralish or slightly alkaline pH. Preservative-free is always a preferable option when you're choosing any lubricant which is to be dosed frequently and for a long time. You want something that stays in the eye longer without causing blurring. It should have all the important electrolytes that are necessary for the health of your ocular surface. And the osmolarity should be isotonic ideally, which is between 181 to 354. And it's very important for a country like ours to keep cost in consideration. So it should not be very expensive. Many of the preservative-free unims are quite expensive and they don't really work out for our Indian population. So what does a tear substitute contain? The main component, of course, is the viscosity agent. But then more than the main viscosity agent, I think the other things are the ones that are really important. What is the preservative? What is the surfactant? What is the electrolyte? And what kind of buffer is the solution containing? And these things actually make a lot of difference. Viscosity agent is usually a polymer or a hydrogel, which enhances viscosity, lubrication, and retention time to promote tear stability. The muco-adhesive properties of hydrogel prolong the contact time of the lubricant on the eye. So what are the types of lubricant viscosity agents? You have cellulose derivatives, which are very common and in fact widely used. You have CMC 0.25, 0.5, and 1%, which is available, probably the most common and cheapest lubricant thanks to price control now. It has both mucoadhesive and viscoelastic properties and a fairly good retention time on the ocular surface. HPMC again has been there for the longest time. 0.3 and 0.5% is available. Again, it has good retention properties, but the disadvantage is it causes crusting at the eyelashes. So sometimes it can be uncomfortable for our patients. Sodium hyaluronate is a newer lubricant which has come into the Indian market. It is a glycosaminoglycan which is present all over our body. It's an excellent viscoelastic lubricant and it has water retention properties. It has a higher retention time on the ocular surface and it is shown to have epithelial migration and epithelial healing properties. So if you are likely to cause epithelial damage, it may be something which is good to use. Carbomers are also popular, like polyacrylic acid and polyvinyl alcohols. PVAs are nowadays very popular. They are synthetic polymers with low viscosity and adequate water solubility, but the advantage is they don't cause much blurring and they have fairly good retention time and they increase the viscosity. Povidones are available, which are polyvinyl pyrrolidine. They have mucomimetic properties, again have good retention. And when they are added to cellulose-based solutions, they supplement both aqueous and mucin components. So give both the aqueous and mucin properties. So, and when added to polyvinyl alcohol, they increase the wettability of the lubricant. Many of these newer lubricants, which especially those which have polyvinyl alcohol and polyethylene glycol, have something called HP guar. This is basically a chemical which essentially it forms a gel when it comes in contact with the ocular surface. So it has a good retention on the ocular surface and protects the surface glycocalyx, especially in areas where it's compromised. So because of the gelling property, it gives an additional tear film stabilizing effect on the to the lubricant. Other viscosity enhancing agents are lipid ointments. They basically replace the lipid component of the tear film, which other lubricants don't contain. So you could use petrolatum, mineral oil, or some recent reports have also shown the use of castor oil. Basically, you're trying to replace lipids and enhance the stability of the tear film, and which certainly has a role in evaporative dry eyes. But other than the viscosity agent, the other important thing to look at is a preservative. And it's really, for me, the most important thing when I'm choosing a lubricant. I will certainly advocate avoiding preservatives which have detergents in them, like benzalkonium chloride, cetrimide, and polyquat. They have the most damaging properties for the ocular surface and the epithelial cells. Oxidative preservatives are probably the better ones. They have minimal toxicity. They include sodium perborate and stabilized oxychlorocomplex. Most of the newer lubricants come with one of these two preservatives. BAC, we all know, is really bad and it causes damage to not just the ocular surface, but also the mucin goblet cells. So it reduces all parts of the ocular surface. And I would strongly not recommend using this for any patient who needs lubrication more than 3 or 4 times a day because of the possibility of toxicity. Oxidative preservatives basically break down to water and oxygen and sodium and chloride. So they're probably very safe and can be used without much worry. Even sodium perborate breaks down to water and hydrogen peroxide and oxygen. Again, very, very safe for the ocular surface. So if you have to use something with preservative, go for one of these. Additives again are very important. And of course, if you can get a preservative-free lubricant, that's ideal, but the cost goes up because either you have to use a very special multi-dose vial, which prevents contamination, or you have to use unims, which again increase the cost per unit. Other additives again are important, like electrolytes, osmoprotectants. These basically are value-added services like for lubricants, and they increase the ocular surface, they increase the cellular health, and they protect the osmolarity of the ocular surface. So how do you go about choosing a lubricant? The choice will depend on the type and severity of the dry eye, frequency of need for dosing, cost, availability, the packaging and ease of handling. For example, if you have a patient with rheumatoid arthritis, you may not be able to use a UNIM, or you have some of these multi-dose vials which need you to press with some pressure, and if your hands are not strong enough, those will not be easy for you to instill into your eye. Patient likeliness of patient compliance and response, and of course clinical preference. Some lubricants work well in your hands. You may trust some companies more than the others. So it's very confusing, but I'll give you some general principles. A more viscous lubricant is selected when there is an increased severity of dry eye. That's a no-brainer. So you would use CMC 1% over 0.5% if your dry eye is worse. Frequency of installation depends on the severity of dry eye, and if you need to instill more frequently, more than 4 times, avoid a detergent preservative. Don't use polyquad or back-containing preservatives. In severe disease, ideally go for a preservative-free lubricant. They really help and they are fabulous. Unfortunately, we don't have too many in India. And this is what I alluded to earlier. If you have problems which prevent you from using preservative-free, please go ahead and use a multi-dose vial. Cost considerations are very important and have to be certainly kept in mind for our kind of a setting. For routine purposes, like garden variety dry eye, you just can use any lubricant. It doesn't really matter that much. But for authentic dry eyes, I think you must keep in mind all these factors. And of course, see the patient's lifestyle and environment, and necessary modifications have to be done for that as well. So these are just some pictures showing different lubricants that are available in our market and the properties that I have. I won't spend too much time. You can just go through these. I'll just stop on this slide. Very often we think that the multinational drop would be a better option, but the multinational option, which is shown in this picture in the top, actually contains a worse preservative, which is a detergent preservative. So the Flogel Ultra or the other one probably has a better preservative, which is easier on the eye. So I'm not saying that this because the sponsor is Cipla, but one must look at the preservative very carefully when you're prescribing the lubricant. Gels have their role, and especially in evaporative dry eye, for a nighttime, you may use them, but you must keep in mind that some of these can cause blurring. So the take-home message, pre-LASIK screening and treatment of pre-existing dry eye is very, very important. So look at the eye carefully before you go ahead and do a procedure. Choose the laser procedure appropriately. In mild dry eyes, you might not want to do a LASIK. Maybe you want to do a surface procedure or SMILE. Most dry eyes after refractive surgery are transient, so don't worry. Just counsel these patients and buy some time. There is no ideal lubricant. Okay, you have to do a case-to-case selection of the lubricant depending on the various considerations that I mentioned. Viscosity agent is important, but it's not that important. I would say the more important thing is the preservative, the additive, and the cost. Thank you.
Thank you, Dr. Rishi. It was a nice presentation on a very tricky topic, and thanks a lot. We are now moving on to the last topic, and that is by Dr. Sujata Mohan. And Dr. Sujata, can we have the slide of Dr. Sujata, please? Admin? Yeah. So Dr. Sujata is the Associate Medical Director of Rajan Eye Care Hospital and specialist in anterior segment surgery. And she is vastly experienced, very experienced cornea and refractive surgeon and cataract surgeon. And she will tell us her experience about how to manage flap-related complications, which have been, a great issue when we did not have the femtosecond laser. The microkeratome LASIK had a lot of incidents of flap-related complications. Let's have the opinion of Dr. Sujata regarding flap complications.
Thank you, Dr. Rajesh Sinha. Okay. At the outset, I'd like to thank Dr. Lalit Verma, AOS, and Cipla, and Dr. Rajesh Sinha for giving me this opportunity. So my topic is going to be on flap complications. And can you see it?
No.
Now can you see it?
No, no.
1 minute. Now?
Yeah, now we can see. Yeah.
I got it. Okay. So I'm going to broadly divide it into two intraoperative and postoperative complications. And intraoperative complication, like someone said, we hardly see them anymore. But this is one which we very recently had in our center, that you can see it's an incomplete flap. And this happened because there was a sudden stoppage of the microkeratome, probably because of an electrical failure. And this is extremely rare, and probably in my entire years of about 20, 25 years, I've just had a couple of them. And fortunately, in this case, as you can see, that the flap is not in the visual axis, the cut portion. And so the chance of scarring is going to be very less. And there could be other reasons for incomplete flap, could be because of loss of suction, accidental release of the vacuum, or a defective blade, and more importantly, a physical obstruction to the passage of microkeratome, either because of a poorly draped eye or because of some eyelash which is blocking the obstruction. So if you come across a incomplete flap, something very similar to this, it's better to just put it back, wait for about 3 months, do a recut either with a femto or with the microkeratome, or a surface ablation a little bit later. So the most important thing is that to prevent this from happening, it's important to check the microkeratome movement every time before surgery. Just make sure that you drape the eye properly. And if you do come across such a procedure, gently reverse the microkeratome so that you prevent any damage to the flap. And make sure that you have enough, if at all you want to continue with your ablation, make sure that you have enough of the stromal bed. Otherwise, you abort the procedure. So free cap is again one of the problems which you can face when patients who have large corneas or flat corneas, or this can also happen because of something called as a stop mechanism, which are present in some microkeratomes. There can be sudden drop in intraocular pressure, and more importantly, in surgeons who are just beginning to operate, they can dehydrate the flap, can actually manually tear off the flap. So this is one of my patients in which I've used a Moria microkeratome. It's almost 15 years back. And the first I went off very smoothly. You can see that the microkeratome is moving very nicely. And when I lifted up, I found there was no flap. Fortunately, I was smart enough to see that, look for it in the microkeratome itself. So once I identified it, I just put a drop of saline and folded it into two. Just tacoed it and went ahead with the ablation. The important thing here is, if you have a free cap, if you've already marked the cornea, pre-placed marks are very important to put the flap back. The other important thing is to make sure that you are keeping the epithelial side up and not down, because then the flap is not going to stick. And this can be done if you have tacoed the flap. Instead of just putting it in a petri dish, then you might not be, it might not be easy to identify which is the epithelial side. And then just make sure that you rotate it so that all the flap marks that you've made, pre-placed marks, are well aligned. It's important to notice that these flaps can be extremely round, and you may not be even able to find out which was the area of the hinge. And once in this particular case, I have a 15-year follow-up on this patient. He just waited for 5 minutes for the flap to dry and then put a bandage contact lens. Alternatively, you can always put a suture so that you don't lose the flap in case the flap moves in the night. But this patient did extremely well, and she's on regular follow-up with me, and I can hardly make out which I had the free cap. So flap buttonhole is again a major problem, and this patient had a flap buttonhole, but fortunately for us, this is only involving the epithelium. And in this case, we just removed the epithelium and went ahead with our usual PRK. So this, but however, in patients who have a stromal incursion where the stroma is also involved, then it becomes a major problem. As you can see in the next case, you can see that the buttonhole is there and it's involved the stroma. So these patients are going to land up in trouble if the flap is not replaced properly. They can develop epithelial ingrowth. And the commonest cause for flap buttonhole are small eyes, steep corneas, patients who have had poor suction, and again an obstruction to the microkeratome pass, or a damaged blade. This again is one more patient who are very, maybe about 5 years back I had it. You can see that's not a complete through and through flap buttonhole, but only a portion of the Bowman's membrane was left behind, and I didn't want to continue with the ablation. So you can see that the Bowman's membrane has not been cut, though the epithelium is still intact on the flap. I just replaced the flap and decided to do a PRK at a later date. So the important points to take home are, if you come across a buttonhole flap, please make sure that you're replacing it properly, irrigate the interface very nicely, make sure there is no epithelial ingrowth, watch these patients very closely, and if there is an aggressive ingrowth, then amputation of the flap may be required. Otherwise, you can go ahead with a transepithelial PRK as you would do at maybe after about 3 to 6 months. So postoperative complications, probably the commonest complications most of us come across is, particularly in a microkeratome flap, is a microstriae or a macrostriae. Microstriae need to be intervened only if they're on the visual axis and they're causing a drop in vision, and very similar to a macrostriae. So here you can see that there is a striae right in the visual axis. So I'm using a Sinskey's hook to break the epithelium. I'm now floating the flap. It's important that you float the flap before you try to release the striae. And also, dilating the eyes will help because it gives you some amount of retroillumination, so you'll be able to identify where the maximum striae are. An important point is, don't try to remove all the striae. What is in the visual axis is the most important. And use 2 Merusal sponges to just perpendicularly stretch the striae on both sides. And this was just a recent post-op. The next day I saw the patient, and just with a little bit of stretching perpendicular to the striae went away, and I put a bandage contact lens. And the patient who had a 6/9 vision improved from 6/9 to 6/5 in 1 week time. You can see the striae, which is in the central visual axis, has improved significantly. Though the fine striae persisting, the patient dramatically improved in vision. This is a patient who had a flap slippage with folds, who came a third after 3 or 4 days. And the problem here is that you can see that the flap is slipped and epithelium is already grown on the stromal bed. And this is going to be a major problem if it's not taken care of, because then the patient is going to land up with an epithelial ingrowth which may persist for life, and it will be a big bugbear, not only for the patient but also for the surgeon. So meticulous removal of the epithelial ingrowth is very, very important. You can use a dry Merusal sponge, or you can use a hockey stick knife like what I'm doing. And then once you've removed the epithelium from the stromal bed, then you can lift the flap, because you don't want the epithelium to grow into the rest of the bed. Then you lift the flap, and this you can see that they're deep, large macrostriae, and these most often, because it's already 2 days old, the patient would have had the epithelium grown into the striae. So it's important that we knock off the epithelium, and here you can see that I'm almost removing 360 degrees, almost all the epithelium, not only the epithelium on the flap, but also a 2 millimeter epithelium around the margin. And once you float it into position, again, do a stretching using the Merusal sponge. That's exactly what I do in all my patients. I use a dry Merusal sponge and stretch perpendicular to the striae, and they do extremely well. I don't have any other technique, and this technique has worked very well for me. And I knew this patient had a very thin flap, so I decided to suture this eye, and used a 11-0 nylon, 311-0 nylon sutures and 110-0 nylon suture. And then I replaced, once what is done, I put a bandage contact lens on this patient. Again, this is a patient who has a very long follow-up. And you can see in 1 week's time, you can still see the 10-0 nylon here. And the patient had absolutely no striae, visual acuity improved to 6/5. And again, this patient has a very long follow-up, and I keep seeing the patient. I'm still not able to make out which eye had the flap. So this is again a patient, very similar patient.
Case shows a similar situation.
So this is a traumatic flap, which you can see that it is folded here and it is already slipped out, and there is some amount of epithelial ingrowth on the stromal bed. So now I'm removing all the epithelium from the stromal bed. It's important to meticulously remove all this, unfold the flap, and also use the Merusal sponge to remove the epithelium. You can use a blunt knife And after doing this, you have to, what I've done in this case is I've used an alcohol, 20% alcohol, so that I can devitalize all the epithelial cells which are on the stroma or also under the flap. This is very important because you don't want epithelial nest to start multiplying once you replace the flap. And then again, using a 2 millimeter area around the flap to prevent epithelial ingrowth very quickly till the flap attaches. So you wait for the epithelium to grow in. And nicely wash under the flap. Just make sure there are no epithelial nests underneath. You can always suture the flap, or you can just finish the case putting a bandage contact lens. In this patient, the hinge was pretty good, and this happened only because the patient had an injury. And so this patient just had a bandage contact lens, and he had an excellent, you can see there's some amount of epithelial disturbance. They just put back the epithelium and fitted the patient with the bandage contact lens. And post-operatively, the patient did extremely well. As you can see in this, a very nicely replaced flap and hardly any striae. So normally these problems are seen in femtoflaps, but we do in microkeratome flaps, but we do come across some problems in femtoflaps as well. And this one patient had an incomplete peripheral cut, probably because of poor energy distribution. And in these cases, it's quite easy to complete the case. You just have to use a Vanna scissors to cut the edge of the flap, and just make sure that you don't strip it off, because then you can have a problem. Just use just a very small bit was left behind. So use the Vanna scissors. And the next one is the flap striae management. And here you can see that I'm painting the flap just to identify where the striae was. And this was a very localized area of striae, but unfortunately it was involving the central area. And so it's always important that you lift the flap completely, just not only the area where the striae is. And this was quite deep. This, you can see now very clearly that the striae are quite deep. So I removed the epithelium over it. And you can see once I've replaced the flap, after repositioning, you can see that the marks which I've done now are slightly misaligned, showing that the flap also had shifted slightly, which was probably the reason for the striae formation. And again, I'm doing a stretching technique and just perpendicular to the area of the striae. And once the flap is replaced, you can see that the striae, the alignment of the marks, you can see are slightly away, showing that there is some amount of displacement of the flap as well. So the last case I'm going to show is a vertical breakthrough. This patient was very uncooperative and had several times had loss of suction. And after about 7th or 8th attempt, we were able to keep her under control. And you can see once the suction was placed again, she tried to move. And as the femto raster pattern is forming, you can see there's some amount of bubble which forms, and again it goes ahead, which is actually the plasma wave going just under the Bowman's, not under the stroma, but fortunately it stopped at this level. Otherwise, if this area of vertical breakthrough had extended a little bit more, it would not have been possible to continue with the case. And because it was very close to the hinge, we were able to lift the flap, avoiding that area, and complete the case without any problems. So this patient had excellent visual recovery. So you can see that I've avoided the area of the vertical break. The same thing can happen. You can have air bubble in the anterior chamber, showing that there is a vertical breakthrough which has gone into the anterior chamber. So these problems can also happen with femtoflaps, though they are not as common as we see them in microkeratome. So prevention is always better than cure. It's important to carefully and precisely reposition the flap, involve the patient in that, and give them good counseling to have adequate protection during day and night. And if you do see a flap striae, early intervention is very important. Don't wish that it will go away. And as the number of days go by, the patient will start noticing the difference between one eye from another. And it's also important to meticulously remove the epithelium from the stroma and use a bandage contact lens and suture wherever necessary. Thank you for the wonderful opportunity.
Thank you, Dr. Sujata, for very nicely showing the flap-related complications. And we will have the panel discussion After this,
Can you stop the screen share, please?
yeah. So it is now time for the quiz, and we will have a short panel discussion after the quiz. So can you stop sharing the slide, admin? I have my own slides. Admin, can you stop sharing?
He's showing the quiz, right?
Yeah. So it's time for quiz. We'll have a short and quick quiz, and I'll just tell you the rules. There'll be 16 questions, each with 4 multiple choices, and you have to note down the answer of each question on a notepad in the sequence asked. You just have to write A, B, C, D, whatever. You don't have to post your answer at this stage. You will be given 15 seconds after each question for you to note down the answers. And at the end of all questions, you will get 1 minute time to post your answers in the Ask the Expert tab on your screen. And answers of all the questions have to be posted together. And the example of answer will be like this, as it has been shown: D, C, B, A, B, B, A, B, C. So it's like that. You have to just write and post it, right? And the answers will be discussed after that. So I start with the first question. And the first question for the quiz is this in front of you. It is, if in zonular dialysis more than 180 degrees, the treatment of choice will be A, CTR, B, CTR with 3-piece IOL, 3 is C, CTR with Ahmed segment, D, 3-piece IOL only. Your time starts now. Okay, time is over. So we move on to the next question. The next question is, which suture material has longer life to fix the IOL in cases of subluxated cataract management? A, Vicryl, B, Silk, C, Gore-Tex, D, all have same decay time, and your time starts now. Okay, we move on to the next question. What is the commonest complaints post-cataract surgery? Deep-seated pain, redness, foreign body sensation and dryness, purulent discharge. Your time starts now. Next question. What do you do when you have a posterior capsular rent? And it is a humor question given by one of our panelists. You panic, or you should panic, or you should go to OT wearing a diaper in anticipation. You should start shouting at the OT staff, or you should just breathe in and breathe out to relax and call a VR surgeon. Your time starts now. Next question. What is the safest way to do a posterior polar cataract? You do a hydrodissection and you do SICS, you do a pars plana lensectomy, or you do a femtosecond laser with cylindrical nuclear fragment. Your time starts now. Next question. What is the best way to do a capsulorhexis in a subluxated cataract? 26 gauge needle, Utrata forceps, femtolaser capsulotomy, or Zepto? Your time starts now. Next question. Dry eye prevalence is higher in Asian populations. The highest prevalence rate was reported in which of the following studies? You can see the options A, B, C, and D, and your time starts now. Next question. All the following are used as topical anti-inflammatory agents in the management of chronic dry eye disease except A, 0.5% ketorolac, 5% liftigrast, 0.05% cyclosporin, 0.03% tacrolimus. Your time starts now. Next question. Which type of LASIK is more often associated with DLK as an adverse reaction? Conventional LASIK, femtolasic, SMILE, all of the above. Your time starts now. Next question. What is more commonly seen in terms of thickness of flaps with microkeratome LASIK? Thicker than intended, thinner than intended, same as intended, none of the above. Your time starts now. Next question. Compared with LASIK, SMILE has lesser incidence of postoperative dry eyes, no flap-related complications, better postoperative corneal biomechanical strength, and option D is all of the above. Your time starts now. Next question. Size of incision in SMILE is 2 to 3 millimeter, 22 millimeter, 2 centimeter, 50 millimeter. Your time starts now. Next question. Which is not a risk factor for post-LASIK dry eye? Age, gender, hyperopic LASIK, low refractive errors. And your time starts now. Last three questions now. Question number 14. Which is the least preferred preservative in a lubricant? Polyquad, preservative-free drops, sodium perborate, stabilized oxychlorocomplex, and your time starts now. We move on to the second last question, and that is free cap in LASIK is seen in all except large corneal diameter, keratometry less than 41 diopters, failure of the stop mechanism, and keratometry more than 48 diopters. Your time starts now. And this is the last question. Flap striae need immediate intervention in all except macrostriae, microstriae involving the visual axis, microstriae in periphery, striae associated with flap dislodgement, and your time starts now. So now you get 1 minute time for you to upload the answers, all the answers together. And meanwhile, by the time the results are being prepared, we can have a quick panel discussion. And before we actually go into discussion, we have one of our panelists who is an eminent smile surgeon, Dr. Krishna Prasad Kudlu. So I would like to have your words on, regarding your experience on smile and femtosecond LASIK. We have been discussing over the last, 3-4 hours. Yeah.
Thank you, Rajesh. It was all ultimate talks today. Probably, I think after a quite long period, I'm sitting for almost 4 hours and listening most of the talks. I think Mahipal sir might have, I think, explained everything about the how the smile has been evolved. Only thing is, sir, like about just one question to Mahipal sir, that about the hyperopic smile. Of course, did you receive any like a trial for this hyperopic smile, and how is the results as such? Do you have any idea?
So receive means, am I involved in hyperopic trials from Visumax? The answer is no. Question as regards whether I have done hyperopic smile in patients, animal eyes, human eyes, postmortem or live eyes, the answer is yes.
Yes.
But obviously, because of the non-disclosure, I'll not go beyond that, but they are in phase 2 trials now, FDA phase 2 trials.
Yes. So, like what Madam was telling about, I think you showed about the even circle software. So, I just wanted to ask you, of course, it's a commercial aspect for circle software, whether we have to pay extra to the company or whether they'll give free of cost.
It depends whom the question is being asked to and how much weight you put. Shri Ganesh and Kudlu from Bangalore and Karnataka don't have to pay, but lesser bottles like us in Delhi have to pay.
No, they'll also charge me. They'll also charge me.
I think the answer is that yes, there is a charge to it, which is wrong, which I have taken up with the company several times, because you don't use a circle scan. It is very infrequently, and it is when a patient needs an enhancement. And normally, if the surgeon is not charging for an enhancement, which most of us don't charge for an enhancement, the company should not charge us a click fee. So that is something which I think Zeiss needs to improve. But as things stand today, you have to pay for a circle scan, but they should not be asking us to pay for that.
Since you have been doing a smile for, I think, quite a long period, I think from when you started till today, did you change your energy setting from the first day till now? Or
brought it down from the factory setting of 32, 34, what it was, and when they started. So we're normally doing it at about 26, 27, 28 now. The energy settings you might change in between also, depending upon if there is a decay in the numerical, the optics or whatever it is. But we have brought it down significantly from what it is. And that was one of the reasons of slight imperfections in the outcomes of the FDA trial, because whenever you are doing a trial, one of the parameters that they fix is the energy and the spots and the line spacing. So what happens is that even if you are getting like a Christmas tree or more OBL, or you are getting less OBL, you are getting cold spots, you are not allowed to change those settings when you are doing the trials and also in the initial part of the machine. But each machine needs an optimization that is very, very important. And this optimization consists of the lowest energy that you can do to get the perfect OBL pattern. as also the spot and the line spacing that you have to work on. So these are the important things that you need to do. And I know how much of brain damage we are doing vis-a-vis trying to optimize for another laser. The energy, the spot spacing, the way the laser is done, I don't know whether you are aware, but not. See, what happens is that if you have a very thin lenticule, and earlier what used to happen was that as you can see that the pattern when it comes from inside out or outside in, so the patterns were different earlier. So earlier when you were doing the second lenticule cut, pattern was again from outside in. So what happened was that it gave more time for the central part of the lenticule to get slightly the bubble to enlarge, and therefore the quality of vision was slightly poorer. Therefore, we want the least time to go into the central part, and the second part of the cut, well, that means the third part of the cut, that means the second surface, it starts now from the center and goes out. So these are small little plays that you have to do with the machine and with the technology, and that takes you to the best results that is possible. So we have reduced the energy. Less the energy, the lesser the chances of having any inflammation and faster recovery. So the optimization of the energy for each machine, you have rightly pointed out, is something which is very, very important.
That is very true, sir. We have also decreased the energy since the time when we started. We started with 33, I think, and now we have reduced down to 28. Now, I just have one query. You mentioned, I mean, to both of you, you mentioned that with Smile we have pushed up the margin of correction.
No, no, no. I didn't mention that. That is the FDA margins that Dr. Ritu was talking about. There is no margin at all in the LASIK. That's the FDA recommendation, and in Germany the recommendation is 8 diopters.
Yeah.
So there is no specific recommendation in India as to how much you should correct. So every one of us has to make our own things. Typically, I follow that I do not wish to leave behind less than 275 to 300 microns, and also that the starting thickness, it should not get reduced. Particular the PTA you have to look at. Now, there is no limit in LASIK as such. I am just talking about the Smile. The Smile machine does not allow you to feed more than -10. So there is a limit in Smile, but for eczema there is no limit. So in eczema, you can feed -16 also if you want. You can feed -18. So none of, but that is the FDA.
No, we used to do it -16, -18 earlier, sir, long back. But
Yeah,
now we have kept a cutoff at 8 diopters, -8 diopters.
Okay, I have personally kept a cutoff at 10. Maybe you are a little more conservative, but Germany, the cutoff is 8. So everyone has that kind of cutoff. So we have kept a cutoff of 10, because the ICLs have become much more better, I would say. As also they are, we have got more confidence on the ICLs now. As also you have Indian equivalent of the IPCL or the FAKIC or the APPA. So there are 3 other companies. So I think they have gained. Some people, even those who do not possess an excimer laser or a Smile, do the ICLs even for small powers.
Yeah. KP, you would like to say something?
No, just a last point about that cyclotorsion component, what Dr. Ritu Arora was telling. Just I wanted to ask Dr. Maipal, like with the rule astigmatism against the rule astigmatism. So suppose if you're treating in Smile with the rule astigmatism, do you overcorrect? Or when you're treating against the rule astigmatism, do you put the same cylinder when you're feeding in the machine?
So I don't specifically make any difference between and against the rule astigmatism. If astigmatism is high under those circumstances, I will mark the cornea as has been proposed by Dr.